I've literally had emergencies. I've responded on the streets. Somebody got hit by a car, and I realized how little I'm able to do. I held his neck. I, held him in C-spine alignment. And I tried to talk to him and assess his level of consciousness, but I don't have an IV. I don't even have a backboard to carry him into the ambulance. So it was very clear. Yeah, I got a lot of stuff in my brain, but that only gets you so far.
Welcome to This Is Not Advice, where you'll hear from successful people in different occupations about how they do every aspect of their job. I'm Roy Bahat. I'm an MBA professor, and I'm a startup investor in the future of work at the venture capital firm Bloomberg Beta. Today, we're going to open the door to the House of Medicine with Dr. Graham Walker, who is an emergency room doctor at Kaiser in San Francisco, has been a doctor for about 2 decades. And beyond practicing emergency medicine, Graham's also a startup founder. He started a company called ND Calc that 2/3 of doctors have used to double check their decisions. And more recently, another called Off Call, in which we invested, where doctors can look up what others get paid and what their working conditions are like. And he also talks to a whole range of doctors on his podcast called How I Doctor to understand how they work. And if you're anything like me, you've been watching the TV show The Pit, which made you immediately want to know, how do emergency rooms actually work? And so for the next few hours, Graham and I are going to talk about exactly what it's like to be an ER doc, how to choose medicine as a career, how to survive medical school and residency, how emergency medicine is a team sport, how doctors think and make decisions under pressure, the role of technology and AI, how to manage burnout and integrating living a life with being a doctor, including what you get paid, the financial realities, and Graham's perspective on how the entire healthcare system needs radical change. Welcome, and remember, this is not advice. Of all the occupations we could be talking about, I kind of feel like if you have you go to the Richard Scarry books for kids about what are the classic occupations, doctor is one of these aspirational, clear what the person does. Now, does that hold up to the reality? I don't know.
Yeah.
And so Graham, we've had the chance to work together because you started this company, but maybe for folks, if you can just share, just give us the précis of your medical doctor experience, and then we'll dive in and start talking about it.
Sure. I'm a second generation doctor. My father's a psychiatrist. I'm an emergency physician.
Is that the same as being an ER doctor?
Same as an ER doctor. My mom's a nurse, and I guess, she's first generation nurse as well. So medicine is newly in my family lineage. I always had an interest in medicine, I think because of my dad. Questioned that a lot with all the pre-med requirements, organic chemistry, all that, but ultimately decided, I want to do medicine. And I continue to enjoy the mix of the human piece of it and the science piece of it. And for me, the tech piece of it now as well. And so went to Stanford for medical school in 2003. Stanford, we often do a 5-year.
Your way through medical school, which, Gramazon is maybe one of my favorite names for a blog that I've ever heard.
Blogged my way through med school when web logging was a new thing at the time.
Yeah, web logging. You were logging your web.
Yeah. And at Stanford, we often do 5 years. Stanford is very generous, encouraging its students to do research. It actually somehow makes med school cheaper to do 5 years instead of 4 with the grants you can receive through Stanford's funding and everything like that. So did 5 years of med school, took a year off and did research in mostly public health and primary care and mental health, and then did residency in New York. In emergency medicine.
It's funny, by the way, that only a doctor would describe a year of doing research as taking a year off.
Oh, I didn't even think of that. Took a year off. Yeah. Did 3 years of residency in emergency medicine. I was a chief resident in my final year. Came back to California, did a simulation medicine fellowship back at Stanford.
You didn't simulate doing a fellowship. You did a fellowship in simulation?
That is the big dummies that are kind of lifelike. They blink and they breathe, and you can literally deliver a real shock of electricity to them, like you're going to defibrillate them. You can give them IV fluids. You can put them on a breathing machine, and we use that frequently in emergency medicine for kind of high risk training to help residents and nurses learn how to handle high stakes situations and communicate clearly and deal with uncommon diagnoses they may come across one time in their entire career. And then joined the Permanente Medical Group and have been practicing there since 2012 at Kaiser San Francisco, 8 blocks up the street from me. And then an entrepreneur created a company called Off Call that Roy, you generously funded, trying to fix physician wealth and well-being through transparency about workload and pay for physicians. And then I should say also created another company called MD Calc 20 years ago now that does medical calculators and were used by like 2/3 of US doctors as well.
I think the range of experiences, including I hadn't realized that you had some research experience too, gives us a lot to work with. And so, as you know, we're just going to try to talk top to bottom through how to be a great doctor. And that is, of course, your podcast is called
How I Doctor. So we talk with physicians who are trying to improve medicine and healthcare, just like I am.
Yeah, and by the way, physicians and also some luminaries in healthcare as an industry, like Mark Cuban, I know you had on, and so folks should definitely check that out. Okay, so some of the areas that we'll talk about the choice to become a doctor.
Sure.
We'll talk about training and preparation, like getting through school and choosing a specialty. We'll talk mostly about the clinical work of being a doctor, which I think in the imagination of most people, when they think about being a doctor, they think about treating patients.
Seeing a patient. Yeah, for sure.
Yeah. Although, as you know, your career already illustrates, research is also part of the occupation of being a doctor. And so we'll talk about that as well. We'll talk about the arc of a career across time. So like clinical work, snapshot in time, but how it evolves across time. And then, zoom out a little bit and talk about the medical system and what's changing in it and how does it. So it sound like a reasonable plan to you?
Sounds great. I was a social policy major in undergrad. So that's the other lens that I really enjoy is like the policy healthcare system piece too.
So let's talk about choosing to be a doctor, because you, in your case, had parental inspiration. Choosing to be a doctor is one of these kind of, I don't even know what to say, like almost like cliche. It used to be. I don't know if it's still the case anymore. But if you were a cliche overachiever, you're pre-med. You're in organic chemistry.
I remember it being a big choice. And you're right, Roy. Most of my friends actually were pre-med, and most of them did not decide to do med school. So I think many people started out, especially if you're like kind of interested in biology, a lot of people start out pre-med, pre-law, engineering students, but those are often like the initial way that I think a lot of people start out in college. And for me, I was like, gosh, do I really want to jump through all these hoops that seemingly are not at all related to medicine, to taking care of patients? Understanding like organic chemistry, electron orbitals, how does that have anything to do with me taking care of a patient with appendicitis or something like that? And ultimately, for me, I was also a tech guy, even as a teenager as well. So for me, I ultimately decided, okay, everything else I can do like on the side or as a hobby. I can do tech as a hobby and teach myself how to code. I can do some policy stuff on the side, but I can't do medicine on the side. Like that's not an option to like just, have a hobby as being a doctor.
At least not legally.
Yeah, not legally. That was one of the ways I decided like, hey, I think I'll take the hoops and I'll deal with the pre-med requirements and actually decide.
And obviously an incredible place of good fortune to be in a position in life where one gets to do that. But I love that insight that there's sort of certain things you can do with your occupation that you can't do just a little bit, at least at first.
Yeah.
And, in grad school, I studied economics. And the reason I chose to study economics is of all the different, I knew I was interested in social sciences and, changing things in the real world. And the reason I chose economics is it was the one discipline, all the other disciplines, I'm not saying that's right, but if you did it, then nobody would ever question whether you could read data or whatever. They might question it, but you'd have the training. And so I love that, the can't do medicine on the side. Are there common patterns that some students fall into when they're thinking about doing it where you're like, that's a sign that maybe you shouldn't do it or you should? Because there are a lot of hoops to jump through.
The way that we, I think, used to talk about going into a surgical specialty is consider everything else. And if you can't think of anything else that you would enjoy or that makes you happy, then go for it. Do surgery.
Almost like process of elimination.
Yeah, I think that actually now applies to medicine as well.
By the way, it applies to starting companies too. It's like you should do it if you have no other choice.
Yeah. I think people should go out and see the world and try new stuff, and or do an internship or volunteer and see, is this what you really want to sign up for? Because it's not an easy road. It's literally dedicating your 20s and at least part or all of your 30s to a profession. And I think, younger generations, Gen Z has a slightly different take on that than I did at the time. But even if you're a Gen Z pre-med or in med school or resident right now, I think it's very clear that medicine is going to eat up most of your free time in some of the best years of your life. So you better really accept that and be excited about it.
As a guy pushing 50, I'm ready for the best years of my life to be now. But I hear you. Is it worth it?
Yeah, I do. I do think it's worth it.
Why is it worth it? What's the prize? Because it used to be high pay, status, and of course, in the scheme of global occupations, being a doctor in the U.S. at least is still a well remunerated, high prestige occupation. But it sounds like it's not what it used to be.
That is the sense I get. That is not what it used to be. But I think it is absolutely still worth it. Is every day worth it? Do I come home like excited and exhilarated? Of course not. It's a job. It is work. Any doctor that says, "Oh my God, I love every single day and every single encounter," is lying.
Right. Anybody who says that about anything is not my kind of person. So what makes it worth it?
A lot of things. Number one, I was talking with a physician about this yesterday. There are not many feelings that feel as emotionally wonderful as making a connection with another human being and legitimately being able to help them. And even though I'm an ER doctor, I don't say save someone's life, because most of the time I don't think I actually save people's lives.
That's a fascinating thing.
One of the first challenge of emergency medicine is just making a connection with this person who often they didn't choose to see you, you didn't choose to see them, but something happened and now you're their doctor. So making that connection and then being able to help them through often what is like the worst day they've ever had for many people. They're in pain, they have something wrong with their body, or they're having an exacerbation of the thing that they have, unfortunately, fairly frequently. A couple times a year, their congestive heart failure flares up, or their COPD, or whatever it is. And being able to take somebody who is in distress or severe pain or can't stop vomiting and providing them with medicines that can help them or an answer to their problems feels incredible. It feels like magic to be able to say, "Hey, I think you have this." And then maybe I get a CAT scan or I do a test or give a medicine that kind of confirms the diagnosis or makes them feel literally all better. It's a wonderful, wonderful feeling.
That intense intimacy does sound really rare. And you're there, of course, for some of the way that a priest is there, or a rabbi is there in the moments that are the most intense moments in a person's life. There's an aspect of that. The other thing that, as you talk about sort of having, your technology interest and your social policy interest, it does occur to me that medicine is one of these occupations where a lot of people who practice it, I'm unsure if it's more than other occupations, also do other stuff. They do invent a medical device. Like that's almost like a cliche, the doctor who's got a medical device company. Or I think about somebody who's a writer or commentator like Atul Gawande or, Oliver Sacks. I mean, I'm sure there's tons and tons of doctors who have taken their reflections about the human experience and turned it into writing. Obviously, Gramazon, and you had it during school. So it does seem like a rare occupation in that way. Are there times where you get to know somebody who's chosen to become a doctor and you're like, you should have known this was not for you?
I think right now a lot of people have self-selected away from that. So maybe they did med school.
So who's left is the fiercely committed.
Yeah. Or, I think there's some people that now maybe mid-career, 10, 15 years in, they think, maybe I should have done anesthesia, or maybe I should have done derm, or should have done something easier.
Like a different specialty.
Yeah, maybe a different specialty. But generally, I think, a lot of the skills of a physician that you learn in med school, even before residency, are widely applicable. How to talk to other people, how to interpret data, how to make decisions when you have not enough information to make a clear, obvious choice. So I think those are really powerful insights that can be used whether you're practicing medicine or consulting or, being an eye banker or something.
I remember when I was a consultant, some of the consultants were people who were had been trained as doctors and decided not to want to do it.
Yeah.
I mean, obviously, you also have that case where people travel from one country to another because medicine, unlike entrepreneurship, it's a licensed occupation. So you can't just show up in another country and doctor. I mean, maybe you can in some countries, but not in the United States.
I think there are even other reasons that it's still worth it to be a doctor. I think the two other reasons that being a physician is still really worth it. One is your access to other medical specialists through what we often call professional courtesy. So if your loved one gets sick, your parent, your partner, your child, and they need to see a specialist, other people, whether they're colleagues you work with or they're friends from med school. I know almost every single specialty that exists. I have a personal connection with almost every single specialty in the United States. So God forbid something were to happen to one of my family members, I can cut the line and get free advice from my colleagues. I can get them in to see a colleague. Someone will squeeze somebody in if I have that personal connection. So I think that is hugely valuable, and physicians don't talk about it because maybe it feels like cheating or something.
Fascinating. There should be a phrase for that. Well, and it's not free of charge in the sense that you've done a lot to get there and you're giving that reciprocal care to others. But it is such a good point about how the medical moments of our lives the moments where we focus on medical care can, in a regular life, a fortunate life, feel like momentary aberrations. We go in to get something, the same way we take a car, back to the auto mechanic analogy, but they're so important in our lives that even just the confidence of knowing you have somebody who is clinically good.
Yeah.
Like being able to have somebody who can say, I know this person seems like an asshole, but actually they're really good at their job.
They're the surgeon you want. Yeah.
Yeah, they're the surgeon you want, kind of a thing. It's sort of the opposite of what was it called? Salem's Challenge that I was reading about, which was, what if the doctor who everybody loves is actually terrible clinically? So yeah, that kind of personal courtesy feels like a big deal.
Yeah. And then the last thing I'll say is I really think medical school teaches you how to learn and teaches you how to learn really quickly. So I'm an ER doctor. I have not read about renal pathology in 20 years. But if I had a patient who came into the ER with IgE nephropathy, minimal change disease, one of these things, I'm
going to assume those are rare diseases related
those
to
are
renal
rare things that those are rare things that I
renal means kidneys. I don't even remember what
it means
means.
kidney. Yeah. I've never diagnosed these. I never will. It's not really an ER diagnosis, but if I saw someone that had it and was coming into the ER for some complication or something like that, I could quickly enough read about it and trigger those neurons in my head to be like, oh yeah, that's what this thing is. And IgE nephropathy means that you should consider ordering these type of tests. So it teaches you how to learn and reacquire and access knowledge in your head that you have long since forgotten. So I think that's extremely powerful as well.
Are there people who you wish would become doctors who choose not to?
I think there are a lot of people who have profoundly better communication skills than many physicians, who I think would be great.
By the way, can I just stop you for a second? Doctors call themselves physicians. I've noticed that.
Yeah.
Why do doctors use that word?
I think there's a couple reasons. One is, everybody can be a doctorate. Some people can be doctorates, of other.
It distinguishes you from the PhD in philosophy.
It does. And then I think physician feels to us like the more appropriate title, the better definition of our career, maybe, or our profession. Feels more professional, maybe.
Yeah, I guess as you describe it, it's more like, it does sound a little fancier, but, extra syllable. But I think it also describes the activity as opposed to the degree.
Yeah.
How the occupation became conflated with the degree is not, like lawyers don't tend to say I am an esquire or whatever it is.
Right. Yes, exactly.
But lawyers do tend to say I'm an attorney. not a lawyer, which is, I was just thought was being fancy. Anyway,
Feels more elevated. Yeah.
yeah. And by the way, we should all be elevated,
Yeah. Yeah.
I don't know how you elevate venture capitalist because it already is so many syllables, but something. Okay. You were saying that there are people with better communication skills than the folks who make it through the gauntlet.
Yeah, I think the house of medicine and of healthcare is opening further as well. Like there are, medicine is absolutely a team sport, and there are social workers and physician assistants and nurse practitioners and everybody who can absolutely help fill other roles that are as critically important as getting to a diagnosis.
Yeah, I mean, it seems from my experiences in the medical system, which fortunately have been relatively limited, that nurses, and I don't even quite know the difference between a nurse and a nurse practitioner,
Sure.
but that nurses, broadly defined, often play an even more central roles. Like the doctor parachutes in for a minute, reads some things, and then makes a face. But the nurse is actually the person who is forging the connection and providing the care. And oftentimes, I mean, we all read about this, like the nurses who turn out more knowledgeable than doctors and dot, dot, dot.
I cannot practice emergency medicine. I cannot save your life without a nurse. I cannot get through a full shift without the help of a social worker, a discharge planner, family members, durable powers of attorney. Like I
Right.
cannot do my job by myself. EMTs, I mean, literally, I am by myself. I can do some things, but I can't do most things without other humans helping.
Yeah, I mean, a sort of bracket on something we'll come back to, which is what that means for diversity of different kinds. Although I know that's a word that now has charge, but I don't care because it's still, like, to me, diversity is a form of excellence, and especially in a team sport. And it also raises for me something else to bracket, which we'll talk about, which is just the role of technology in being part of the team and AIs and all that. Okay, but let's just say person has decided to be a doctor. And I'd like in the system to talk about, like, should schooling requirements be lessened, that kind of thing, so that we can have, more people do this kind of stuff. But a person's decided to be a doctor, and then there's sort of one choice after another, it seems, because I don't even know exactly when the choices come up, but like you match with a residency, and is that when you choose your specialty? The big question is, what are the choices you make along the way, and specifically specialty?
Yeah, sure. So, you do your pre-med requirements, and then everybody takes the MCAT. I mean, really, taking the MCAT is the first in like 15 to 20 years of standardized testing. And like you are like starting in the tunnel, and there's not an end to the tunnel for 15 years. Like once you've taken the MCAT and then get into med school, I guess the one call out is
the beginning, not the end, to take the MCAT.
The one call out is there are MD and DO schools. Medical doctor and doctor of osteopathy. They provide very similar training. The DOs actually have a little bit more training in terms of like musculoskeletal medicine, generally speaking. But besides that, yeah, you do 1.5 or 2 years of preclinical medical school. So that's taking anatomy lab and dissecting a cadaver. It's genetics, it's physiology, pharmacology, pathophysiology. It's, think of it like college classes. You buy textbooks and you get tests and quizzes and all that stuff. And then you take another test called Step 1, which is a test of all that preclinical knowledge. So preclinical, before you actually start seeing patients. This knowledge thing of preclinical knowledge grows and grows over time, of course. So the tests are much harder than when I was in school 20 years ago, because now we have more knowledge, we have more information. Med students are now expected to memorize even more facts. And then after 2 years, you finally get to start seeing patients.
Those 2 preclinical years, how useful are the things you learn for the practice of actually being a physician?
Much of it is useful, but you don't know during the time which of it is useful.
Got it. So it depends on what your path will be. All of it is useful for some path.
Almost all of it. Yeah.
What was the most useless part?
Well, like there's a part of your body called the brachial plexus, and it's right here. It's like kind of in your armpit, and it's how the nerves of your spine get into your arm. And the way they branch and turn into these branches and cords and trunks, you have to memorize this like almost visual sequence of how these nerves get into your arm. And personally, I think it's worthless. I don't think there's a reason to ever teach anybody, force people to memorize it anymore.
Does organic chemistry matter to treating appendicitis?
It does not at all. There are ways that it's helpful to know that, say, sodium is on the same column of the periodic table as lithium, because if you have a patient that's on lithium, they can have sodium problems. That's kind of like it explains the reason behind it. It's a fun chemistry fact. But do you need to know the orbitals of electrons of an iron atom? No, it's worthless.
I don't think medicine is the only one in this, but it does seem like a couple of factors happen in pre-professional education. One is some of it is just supply and demand regulation.
Totally.
Hey,
It's
one
weeding
point in
out.
the past, we had more people who wanted to be doctors than we wanted there to
Correct.
be doctors. And so let's just make them jump through some irrelevant hoops. And then the other piece of it feels like there was a time when human memory was the most reliable tool for accessing facts at the moment at which they were needed. And so we practice that skill, and, just the educational change in what's needed, I think, has such a long lag time, in part because the signals don't feed back fast enough in terms of what's useful. But the other thing is, look, especially with medicine, you change one class and it has unexpected consequences and people could die. And so obviously people are going to be very small c conservative in making changes to medical preparation, given that. You were describing finishing step one, and at that point, you continue on into ...
They let you in the hospital. And so you will do, everybody does standard rotations. They're all a month long or 2 months long for the more fundamental ones. So internal medicine, general surgery, pediatrics, those are all 2 months long. Maybe OB-GYN is as well. And then you have electives.
What is internal medicine, by the way? I've heard that a bunch of times, but it seems like, I don't know, isn't most medicine except for dermatology internal?
Yeah, think of it as just like adult medicine. It's the medicine of adults, and then under internal medicine are almost all of the medical subspecialties. So for some reason, not derm, but nephrology, cardiology, endocrinology.
Well, derm is external medicine. That's why.
Most of the organs fall under internal medicine. You go through all of these rotations and you're seeing patients and you're supervised by an intern and a resident and a fellow and an attending. And you're just learning
I don't even know
how
really what those four are, but maybe we'll get to that.
Yeah, we'll get to that.
Yeah.
And so you're just learning how to really just start talking with patients. Real patients. There's practice patients that you've maybe seen previously, but real patients with real medical problems.
Practice patients, like medical schools hire actors to role play being a patient?
Yeah, they're called standardized patients.
Whoa.
Yeah,
That's cool.
You,
I didn't know that.
You have to practice. Yeah,
sense.
you practice just talking to a human
Yeah,
and trying to
for sure.
remember what questions to ask them and
No,
how to
I think that's
examine
great.
them.
I think that's hilarious. And they have a script basically that
Totally.
like has a logic tree of some kind that they follow.
Absolutely. Yeah. So you start seeing patients and you really are just you're at the bottom of the totem pole, and the bottom of the totem pole starting out is just learning how to collect data. So collecting data would be talking with the patient and collecting data that way and examining them. Collecting data would be looking at their vital signs and their lab tests from the night before and seeing what those really just collecting it and recording it.
That pad of paper that seems to be on the foot of the bed every time.
In your beginning as a medical student, you're not synthesizing that data. You are just the collector of the data. And you're learning the steps into how to write a medical note. So that's going to be, the subjective stuff, the objective stuff, and then the plan for the following 24 hours, say, if you're in the hospital. And, that takes a year to really get
the hang of
memorized and in your head. And so you're doing all of these different rotations. You also have elective times where you can say, yeah, I'm really interested in urology. So I really want to do urology so I can see if it's for me, or derm, and then you'll do a specialty month called a sub internship. And that is a way to kind of prove yourself as like a really good med student, because you want a really good letter of recommendation when you're about to apply to residency.
Okay, but at this point, you have yet to really, other than choosing some elective classes, you haven't made any irreversible choices.
No, there are no irreversible choices until you decide what specialty and where you want to apply for residency.
And so residency is A year, 2 years? What is residency?
Residency starts with an intern year,
Okay.
1 year. And so essentially the first year of residency, we just call everybody an intern, but it's all kind of contiguous with residency. Yeah, but they're a resident. They're an intern resident. And then residency can be anywhere from a minimum of 3 years to a maximum of, I want to say maybe 7 or 8 for, I want to say I think neurosurgery is maybe 7 or 8. And then you can further go on to subspecialize. So if you're a neurosurgeon, you could then say, well, I want to only do kids. And so that's another several years of a fellowship to get subspecialty additional training. And then once you're done with fellowship, some people could technically do another fellowship, but most people are by that time in their 40s and they're like, I would like to start practicing as an attending.
What's the difference between practicing as an attending versus you've been doing the thing for 7 years? And at that point, you are relatively far along, picking one of the more advanced specialties. But what is the difference?
Yeah, I mean, if you're a 7th year chief resident of the neurosurgery program, you are operating almost entirely independently at that point, and you've gained the trust of your supervising attending doctors. Really, it is the fact that you, as an attending, you're operating under your own medical license.
You are the one making the choices ultimately. You are responsible for what happens.
The buck stops with you.
Got it.
Versus when you're a resident or a fellow, technically there's somebody above you that is ultimately responsible in making the ultimate call. Should we do surgery? Should we give this medicine? Should we not give this medicine, et cetera?
And in the mind of a physician, is medical school is typically 4 years, right?
Yep.
And so in the mind of a physician, is there a huge difference between the last 2 of those 4 years where you're doing those clinical rotations and internship residency? Or does it just kind of feel like, well, I might switch which hospital I'm at or what city I'm in, but it's basically more of the same?
Oh, yeah. The first 2 years, those clinical years of med school are very different because you're an undifferentiated stem cell. You could go into OB-GYN or pediatrics. And in fact, Roy, the thing that's way easier for almost everybody, myself included, it's way easier to know what you don't want to do than what you do want to do.
Fascinating. Okay, so give us the wisdom. I want to talk about how to get through school and your Gramazon blogging experiences, because that was if somebody wants like an anthropological look at what the various aspects of making it through medical school are, I think it's just a great artifact of what blogging was like then, because Substacks are not like that anymore. Like, it really was a diary in a sense.
It was a diary, yeah.
It was a diary. And that's a different way than how people tend to write today. And I think it's really a powerful artifact as a result. But what should people know about choosing a specialty?
Within your first week, way easier to say, oh, yeah, this one isn't for me. I have to get.
I'm not into urine.
Yeah, I have to get through 3 more weeks of this. But hey, this was a good experience because now I know that I really don't like eyeballs or whatever it is. But
right,
and then
exactly.
The other key piece is because the specialties have different work and that different work attracts different personalities in humans. The other way to find out what specialty you want to do is if you like the people in the specialty.
Yeah.
If you think a cardiologist is really like the way they carry themselves and the way they talk and the stuff they do is really cool, then you want to be a cardiologist. If you're rotating on OB-GYN and you're like, yeah, I just don't really care for these people are fine people, but it's a vibe. That's what it is. It's a vibe. And I vibed the best with emergency physicians. We're kind of sarcastic. We're kind of snarky. We have a dark sense of humor, but we like adrenaline and we like, rapidly solving problems and,
chill under pressure.
And the other reason here, Roy, is you don't really know what it's like to be an attending when you're a med student. It's just different. It's just, you can get a general sense of what it's going to be like being an OB working on labor and delivery, working night shifts in your 50s, but you can't really know what that's like when you're a 26-year-old med student.
Yeah, I mean, I noticed in our lives, some of the doctors we're close with do seem to sort, not quite by personality, but by like something about preferences of their community, maybe is a way to put it. Like,
sure, yeah.
I'm thinking of you, Dr. Chapman, who delivered our babies, and the crew of people who she was doing OBGYN with, and then went on to do gyn-onc and other stuff, seemed like they were a cadre, they were a cohort,
Yeah.
they had a
Yep.
thing and a bond. And so there's the people, there's, do you think you will like the work? And what are the other factors?
The people, the work, and then I think the lifestyle piece
Like some
of
are
that as
easier
well.
and harder, some pay more and pay less. Is that what you mean?
Yeah,
more or less hours.
There's an acronym called the Road to Happiness, and the road
Okay.
stands for I don't know if the R from radiology is hurting right now, but the Road to Happiness is radiology, ophthalmology, anesthesia, and dermatology.
Got it. Meaning those are the 4 happy ones.
Those are the lifestyle specialties where the lifestyle, the ratio of like work or dissatisfaction to pay is really good.
When did you know?
I was exposed to ER doctors who taught like our procedure classes before we were in clinical.
Procedure classes means you're in the first 2 years in the classroom and they're teaching you about things like how to suture something.
How to suture, how to do an EKG, how to do an ultrasound, things like that. And I was like, oh, I like these guys. These are, they're really hands-on. They get to fix stuff. So yeah, I knew pretty early that I liked emergency medicine a lot, but I liked a lot of specialties. I'll tell you, I liked general surgery. I liked the way that surgeons think about the world, but I couldn't stand on my feet for that long. Like,
yeah, I noticed all the clogs
standing
that the surgeons seem to wear. I don't know if they still do. If there's better footwear now.
I mean, surgeons can do 9-hour surgeries without stopping to pee or to like my back would hurt. It just standing there. And so I was like, yeah, I actually love the surgery personality. I like the way they think about the world, but no, I can't.
There was just a disqualifying fact in it.
Yeah.
The same way I chose my college major in part because they had a statistics class that was required. And I was like, I like statistics. I'm going to choose this whole major because of one required class. It's like, yeah, I kind of did.
So yeah, it's easier to rule stuff out than it is to know for sure. I really liked family practice docs. I liked internal medicine, but ultimately I really liked the idea of often in emergency medicine, you get to take somebody who's really miserable or suffering with something, and within a few hours, many of them are like a lot better. So migraines, or you get a stomach bug and you can't stop puking. Like
there's like an immediate reward, unlike managing somebody's slow decline over many years. That makes sense. What if people are wrong?
There's, I would say, less than 1% of people do switch. So you can get a couple years into residency, and
meaning you're kind of stuck.
You're mostly stuck because you have to start over. So you could do neurosurgery.
Is it a black mark on somebody's career? Is it a negative signal if they have to restart? Like, can you have a successful career switching?
Oh, you can have absolutely a successful career. It makes it really hard. It is very hard to change, though. People question and think, well, why didn't you know earlier? What's wrong with you? You're not committed. How are you going to prove that you're committed to this specialty if you weren't committed to that one? So
people ought to think of it as a one-way door, is what you're saying.
Yeah, it's a pretty much a one-way door. I mean, technically, I think technically even I could still go back and do a residency today. I could apply to the match and say, yeah, I don't want to do emergency medicine anymore. I want to do derm. I think I legally could, but I don't know if anybody would take me.
So now let me just ask about the experience of surviving all this training. So you are, the way I think about it in medicine is, unlike most occupations, there isn't a really bright line between the learning phase and the doing phase.
Yeah.
The doing gets incorporated into the learning in a way that, law students don't have required rotations in the courtroom in quite the same way. Entrepreneurs don't have training pitch meetings. Maybe they do, but it's a bit more gradual. And yet the experience of going through medical training just sounds like one of these, I don't know, almost like apocryphal, how grueling it is.
Yeah.
That people tell these stories about the misery of going through it in ways that almost seem incomprehensible to folks who don't do medicine. I mean, some of it sustains in the occupation, but you got to stay up all night every fourth night. I'm just making up what the specifics are. You can tell me. So first of all, how bad is it? And how do people survive it?
I had a wonderful mentor. His name was Dr. Quentin Young. And Quentin famously told me, that medical training is the world's best behavior modification program, even better than the military.
Mm-hmm.
I think he was in the Army, and he said it's even better than the Army. The ability to force a human being to think and behave in certain ways because the training is so challenging and grueling, and there's such an immense amount of pressure and weight put on you. You are dealing with people's lives, and you are like in the middle of learning how to do it, and you're also making decisions that are technically supervised by somebody above you, but your attending can't check every single order that you write on every single patient and review it and make sure it's accurate.
Yeah, I've had that experience as a patient where it's like, I know that there needs to be training of doctors, but does it have to be on me?
Yeah.
Kind of thing. Oh, it has to be on somebody. It's a not in my backyard kind of a not in my hospital bed phenomenon.
Yeah, that was the entire subject of Atul Gawande's first book. Is like, how do you ethically deal with this? Nobody wants to be the first patients you've ever done surgery on, but somebody has to be. Otherwise, we run out of surgeons.
And I was thinking about it. Some of the, you and I were talking before about readings, and we'll talk about some of them. But one of them that I read years ago was that novel House of God, which seemed to be a lot about the learning experience. And obviously, all the TV shows, are all like, it's never a bunch of attendings standing around. It's always somebody learning and somebody more senior, and chief resident seems to be the boss, but I guess they're actually not. So I understand the stakes, but it does seem like there's some mythology around how difficult it is. So I understand the effect too, is that it's a training program, but why is it so difficult beyond this? Is it just the stakes? Does it need to be as difficult as it is? And how do you as an individual make it through?
I don't think there is a way around it without it being challenging for a couple of reasons. Back in the 2000s or 90s, there were work hour restrictions placed on medical residents because of some famous cases where patients were harmed because people were up 36 hours, or they were on call, every other night, and not getting enough sleep, for example. And so those work hour restrictions, maxed out at 80 hours a week, averaged over 4 weeks. So you technically can work 100 hours as long as, you average that out with 60 hours.
Yeah. Right. Balancing out with your 60-hour week.
Yeah. Just that easy 60-hour week. And, the trade-off that we made in medicine by doing that is it required us to implement just different ways of cutting up the hours. So it used to be that you might stay in the hospital from 7 a.m. on Tuesday through like 3 or 4 p.m. on Wednesday, because you have a full day of working in the hospital. Then you're the team that admits all the patients from the ER all night long. So you sleep in the hospital, but if there's patients to admit all night, you actually don't sleep. And then, you got to go see the patients that you saw the prior day on Wednesday morning and see them all day. And then you get to go home, and maybe you try to cut it out early. And so you actually leave by 12 or 1 or something like that, but you may not have slept at all for that period of time. The benefit of that, Roy, is you get to see the patient that you get to see continuity. Yes. So the patient that you admitted at 4 p.m. the day before, you came up with a treatment plan. You started them on antibiotics and fluids, and you gave them a breathing treatment. And that next day, you're like, oh my God, they're better. That's incredible. Look what I did.
In your blog, one of the most touching pieces to me was the patient who you saw who you didn't expect to die. And then the next morning,
I'll never forget him. Yeah.
Yeah. When you first encounter in the context of your work, the tragedies that come with the work.
Yeah.
What is that like?
It feels greatly unfair, like in your face, tells you that the universe is not fair and is cold and lonely for sure. I'll never forget. I had like a really good relationship with that patient. I remember I'm imagining exactly what room he was in the Palo Alto VA in the step down unit.
What's a step-down unit? VA is Veteran Affairs Hospital, which, by the way, I think is probably the largest hospital system in the United States, right?
Yeah. Veterans Affairs Hospital, and many medical centers, academic med centers, have an affiliation with their local VA hospital. They trade off, they exchange faculty, and med students rotate there, and everything like that. A step down unit is a unit less intense than an ICU, but more intense than just a regular medical floor bed. And yeah, this guy was slowly making improvements, and I would see him every day, and he was so friendly and smiling and wonderful. And I just remember coming in, I would say bye to him like at 5 p.m. Hey, I'm going home for the day. See you tomorrow. And I remember he wasn't in his room that morning, and he ended up getting, something happened to him overnight, and he ended up going to the intensive care unit. And I think the following day he died. And I was just, he was my first patient that that I felt like I lost. Like, I knew of other patients on our team, but he was like my patient. He was like the one that I really felt like I owned, that I knew the most about him. I knew his story like the back of my hand. And so I remember it feeling very isolating, and really unfair that like this great guy who had been improving every single day. Like, he was really sick when he came in, but every single day he was making like, oh my God, he's got to go home soon. And I also remember it being very lonely, because while it was my first patient that I lost, it was not anybody else's on the team's first patient. And so
you were going through an experience that they were not going through.
They'd already gone through that experience, probably also alone. And so I didn't feel like they comforted me at all, because to them it had become routine.
Yeah. And what's amazing to me about the medical training stories that I hear is, it's like you're working really hard. Somebody is, in this case, a more experienced physician is not providing you with comfort. And maybe there's an implication there that it would be nice if they did.
Yeah, sure.
Or somebody's getting treated harshly by a more senior physician. And then somehow when the people become the senior physicians, it doesn't seem to change. Like the cycle continues, kind of a thing. And it just occurs to me as you're describing this, something really obvious, which is, in addition to the grueling work in terms of hours and intensity, which sounds a lot like, in some ways, a more physical and intense version of being an investment banker.
Sure,
you pull the all-nighters and but like there, you're like just sitting at a screen. And the stakes are big, but they're financial. And that's different than life or death. But that doesn't have anything like the emotional labor involved in being a physician. And so let me come back to that core question, which is, how do students make it through?
I think there's a lot of commiseration with the other students that you're working with and your friends. You've also gone through some weird stuff already. You went through anatomy lab, which is also strange.
Right. You've sort of, the top of the jar got loosened a little bit, because you also worked all night studying for organic chemistry in college. So there was some hazing along the way.
Yeah. And then I think, I think support of friends and classmates. And I think the culture of medicine is slowly changing, but slower than I would like it to be. I think it is generational. Like, I see the stereotype of like the general surgeon that's like, very short with you and not friendly. And, I think that's changing. Like, I see the surgery residents that I consult in the ER are often like really friendly. And I'm like, you're sure you're from general surgery? Because they're like actually very nice and helpful. No shade to my attending colleagues in general surgery. But, I think it is slowly changing. But yeah, I think probably, Roy, part of the reason that physicians have like really dark senses of humor and like maybe come across as cold or uncaring to patients sometimes, or much of the time, is because we have seen some really dark stuff and really unfair stuff. And it has impacted us so deeply, in fact, that we cannot allow that to get in deeply all the time. Otherwise,
couldn't function.
We would be a wreck. And it's weird, but maybe once a year, or maybe even less now, we'll something that I see in the ER or a patient I had will really upset me. And I'll cry, I'll like break down and lose it. And I weirdly like am really happy when I do because it reminds me there's still like
A human
a
in
heart
there.
in there. Yeah, yeah.
Yeah.
Like because most of the time I can break really bad news with people, and I feel it, and I show it on my face, but I can then come home and like, oh, I'm back to what's on Netflix tonight?
I've had the sense at times that doctors are performing empathy
Oh, sure, yeah,
with
yeah,
me,
yeah.
which I would rather they perform empathy than not perform empathy. And, it's kind of an unreasonable assumption for them to have the same emotion. In fact, I don't want them to have the same emotional experience I'm having because
Sure,
I
you're right,
want their
yeah.
brains unclouded by that, if that clouds them. And so, like, the idea of an ER doctor who would be crying at every turn, it's like, no, man, I need you to like know which cart to wheel in or whatever, what medicine to call for.
Yeah, yeah,
And so being clinical, for lack of a better word to
yeah.
use, I get is an advantage. If somebody comes to you, they say, what do I need to know about getting through my school and training to thrive as a person, as a doctor, as a person and as a professional?
So I think what you need to know is it's okay to have other interests. And in fact, those are going to be the critical things that keep you human. Much of the process pulls away your humanity, sometimes for good reasons, and sometimes because the process is so daunting. And you'll recognize things you'll say or ways you behave that you probably feel a little ashamed of sometimes. That you like, I could have said that better. I could have handled that better to another human. That I'm supposed to be helping them, and they're the ones that are hurting. It's keeping touch with your humanity and the things that you really care about. Those are the things that make it easy to connect with the person and to read the person and understand, like, hey, is this going to help this person if I crack a joke right now, or is this going to be the wrong thing to do? And so I think that's a really important thing that you hold on to. I like musical theater. I like programming. I like baking, whatever it is that keeps you human, to be able to make those connections with other colleagues, nurses, patients. And I think that the younger generation's better at this than I was. They are way better at not viewing this as just a calling that you have to give up everything for, but viewing it at, hey, this is a job. I want to get paid for these services. I'm willing to help you and figure this out together, but this is a job and I'm not going to lose myself.
It's so hard to overgeneralize about generations. It's so hard to generalize and so easy to overgeneralize about generations. One of the things that I believe is that the attitude toward work that people seem to have in younger generations,
Yeah.
they have more perspective and at the same time scarier so like less all consuming in terms of identity and scarier in the sense of like, well, it's a lot harder than it was. I mean, the prize for being a cardiologist was a bigger prize then than it is now. And do you watch the TV show Billions?
No. Huh.
So in that TV
I've
show,
seen it. I've seen.
Yeah,
I think I watched the first season. Yeah.
but there's like a very intense environment in one of the investment firms, and they have a therapist on staff.
Oh yeah, yeah, yeah.
And I've always wondered about, in medical training, is there a therapist on staff? The complaint that, that many busy professionals make, but especially doctors, of like, I really could use a therapist, but my schedule doesn't allow. I mean, there's no therapist available at 3 a.m. when I need one. And so what is the support available, and is it sufficient for the task at hand?
Royal, I'll tell you the sad truth about medical culture is that I think this is changing, but I think seeing a therapist or really needing help is viewed very negatively.
Still.
I mean, I publicly see a therapist. She's wonderful. She's helped me a ton. And I talk about it publicly because
I mean, you feel like that's like a weird thing to admit, because I got like a lot of therapists. I got like a trench coat full of watches of therapists.
It is a sense in medical culture that asking for help or needing help is a sign of weakness.
Weakness is a problem because that may mean you are not as talented a doctor.
not as talented as a doctor. You are not as competent. A lot of doctors, honestly, even have trouble saying, I don't know. I think there's some societal pressure. They have some internal pressure that the doctor's supposed to know everything. I don't think that's true. I say I don't know all the time. I say what I do know and what I don't know, but there is often a sense.
But you feel that that's rare.
Generally speaking, yeah, with many physicians, it's a sign of weakness. And in the same way that needing help of needing a therapist.
Do you think that the fact that your dad was a mental health
totally
doctor may have influenced that?
100%.
And by the way, presumably psychiatrists don't get judged for needing a psychiatrist.
Correct. No, that's like an ethical requirement because they get all this transference and reverse transference and all this other stuff. There are programs to help physicians. And again, this is changing. I'll just put out a call for, there's something called the Physicians Helpline. This was started by a psychiatrist during COVID, where physicians were really obviously struggling for lots of reasons. And it's like a 24/7 helpline that you can call, and it's staffed by psychiatrists who just volunteer to help other physicians. Every hospital has a mandated program called EAP, which is the Employee Assistance Program. It's intentionally given a vague name to try to not be.
By the way, many corporations have the same thing offered as a benefit, but it takes on a totally different valence if you're a venture capitalist versus being a physician.
Yes, we had a very unexpected death of a patient that I took care of a young, previously very healthy man, and it was extremely upsetting. I mean, I saw nurses who've been nurses for 30 years just bawling their eyes out. And so, a couple days later, we actually had our EAP therapist come in and kind of had an open session. Hey, anybody who wants to come talk about this stuff? And, it was extremely powerful. There were med students in the room who did CPR on this young man, and that was their first death. And so I saw myself in this med student who, was experiencing the first loss of their first patient too. And so I think EAP can be tremendously helpful. Therapy, of course, can be tremendously helpful. But it is taking us in the House of Medicine some time to be okay with asking for help, which is crazy.
Yeah, that is crazy. I love the expression, the House of Medicine. The thing it brings up for me is, and we'll talk more about technology a little later, but there's this bundling that happened in many occupations, which is that the delivery of the service and the delivery of the connection between two human beings came bundled together. I mean, the truth is your lawyer does that. Your accountant does that on some level. I mean, we all do that with coworkers.
Yeah.
And in all walks of professional life, there's a challenge about how do you integrate those two things? Because obviously your doctor is not your friend. They're not there, but you may feel very close with them. And I just wonder whether, as the role that different services play, of even things like a pharmaceutically prescribed medication that may help with something, alleviates some pressure on the doctor to be that healer in that way and allows for the human connection. Because in a way, I think what many of us want is that human connection. Like if you could bring in a robotic doctor who had all the diagnoses in their head and was clinically the most competent doctor imaginable, more competent than any human being. And my guess is, we'll talk about this, my guess is doctors already diagnose more poorly than AIs. But, I'm not sure if that's true, but it will be true at some point in the not too distant future. Whether we can distill out just that powerful piece that you started with by talking about connection. Is there anything in medical training? I mean, the way you describe, well, I didn't save that person's life, however you put it, we were part of a team that enabled them to discover their own capacity to save their life, whatever it was, which I'm not trying to be disparaging. I think it's a really important reframe.
Yeah.
Does medical training prepare physicians to forge connections with patients?
Oh, what a great question. I think maybe on a bit more of a superficial level.
It teaches you the pattern of like, first ask this question.
Yeah. Like pattern. It's another pattern. But I mean, I think, we do have training and education on how to talk with patients about serious illness and deliver bad news, often the worst thing that somebody's ever been told about them. I think often a lot of that gets suppressed or washed away during residency training because just the onslaught of learning the medicine piece is so intense. And then really it's your first years as an attending where you're actually realizing how important the human piece of you is. Like,
You come back to it kind of at the end.
yeah, in residency, what is rewarded is the correct diagnosis and the correct treatment and, getting patients admitted really quickly and discharged and getting all your tasks done. But as an attending, the medicine piece often is much easier because you did the residency piece. And now it's like, how do I convince this person to take their medicine? How do I tell this person something really bad? How do I work with this person who has certain challenges? And all that comes back to influence. Like, you actually realize as an attending how little power you have as a doctor. If somebody comes into the ER, I have 6 hours to have an impact on their life. And if they survive those 6 hours, they're going to go off and live for another 50 years. And I may never see them again. And so you really realize you have to be able to influence people. You don't have the power. You don't control people. I don't force people to take their medicines. I have to use influence and not trickery, but like find ways to motivate them to do the things that I think are in hopefully our both of our best interests.
Look, I mean, how much of my GP, my time with me, and I have an excellent GP. Thank you, Dr. Swan. She's great. And I recognize that a lot of the nature of the interaction that I have with her is her trying to figure out ways to get me to do stuff. Because you would think the transaction would be as simple as, please exercise.
Yep.
But then one time I remember she said to me, I'm prescribing you exercise or something like that. Maybe she didn't exactly. And it worked for a few days. And then it stopped working. But there are, like, human psychology is just so complex that I definitely get that if what you care about is the health outcome, then influence is maybe a more important lever than medicine for achieving that outcome.
How can we get aligned? Somebody on Twitter wrote this and they said, like, the challenge of medicine, outpatient medicine in particular, is like every 15 minutes you have a different meeting with a different person. And the two people in the meeting often have a totally different agenda. And the meeting ends in 15 minutes. And you, by the end of it, you hopefully have come to some agreement about something. So like, it was a great way to frame to kind of like business people or people outside of healthcare. Like, imagine you have a different meeting on your calendar every 15 minutes and the agenda is, you don't even agree on the agenda.
Well, and also that it's intense in terms of it's not like a regular meeting. This is literally a meeting with life or death stakes some of the time. And so you add that into the whole complexity of the thing.
The other challenge of medicine is that we physicians tend to practice very similarly to how we were trained. And so, in a few years, I'll have practiced emergency medicine for 20 years. Now, am I practicing the same way as...
How is that possible given you are only in your mid-30s? But let's continue.
My boyish good looks. Now, while, there are a lot of things that I've changed about how I practice medicine, but a lot has still stayed the same. Some of that is really good. I have foundational things that I always do because these are the keys to being a good ER doctor, is never waver around whatever it is, tachycardia or, never miss a fracture, whatever it is. But then there are other things that, like, in the past 20 years, there probably are better ways to skin a cat or handle a particular challenge in emergency medicine. And I haven't changed. I haven't changed my ways.
Well, we will talk about getting better at the job and ongoing education and learning too, because I think that's important. On the clinical work, and maybe does doing paperwork count in administrative?
No, often paperwork is part of clinical.
Okay. So when you think about the elements of clinical work, it's just your day as a doctor. What's the map in your head of what the work is?
In emergency medicine, the map is, there's a map of what I hope it to be, and then there's the map that is created dynamically as the day happens. And that map starts out with, I'm a morning person, so I typically prefer morning shifts. Like tomorrow I'm working at 6 a.m. and then Sunday I'm working at 7 a.m. And so 6 to 4 and 7 to 5. So that map is, I know I'm going to take sign out from the off-going night shift doctor, the other attending, and they're going to tell me about the patients who are still in the ER under their care and what's going on with them and what I need to do to help get their care kind of completed, either admitted to the hospital or sent discharged home. And that map then includes like,
because the ER is sort of a vestibule on the way into the hospital that people like. Is that the way to think about it?
Yeah, ultimately we are deciding if you need to be hospitalized or can you go home. That is, we call that disposition. And in emergency medicine, all of emergency medicine is dispo, dispo, dispo. Do I have enough information to make a decision about that? Can I send this person home or do I need to admit them to the hospital? Do I need more information? And then of course, can I treat this person? How can I help them? Even if they're not having an emergency, we are very proud of the fact that we don't know if you have insurance or not. It's illegal to ask before we start treating you. So we're really proud of that fact that we take care of everything. So on my shift, I'll, take sign out and then start seeing new patients. And it could be that tomorrow is kind of a SLOW. We're very superstitious, like a reasonable morning. Or it's possible that I could have 10 patients from 6 to 7 a.m. until the next doctor comes on who all want to see me immediately. And so it could be that I've got some time to catch up with the nurses and check in with the patients from overnight. It could be that there's 2 heart attacks and a stroke that show up, and I have to be juggling all those patients all at once with very little help. And then the rest of the day will kind of sort itself out. I'll maybe get some sicker patients that I need to put more attention and time into, thinking about what could be going wrong with them, knowing who I need to talk to, which consultant from the hospital I need to ask for their assistance on a case. And there's other patients that have something really straightforward and obvious that I can just walk in the room, talk with them, examine them, and actually immediately have a plan in my head. Oh, hey, you need some antibiotics. I'm going to send you home.
And so the core kind of interaction is attempting to understand what the patient is experiencing. I don't know if diagnosis is a technical term only used in certain moments, or if it and then provide that care, basically, either by referring the patient to somebody immediately within the hospital or by giving them the care right there, or saying, okay, but you in 2 weeks need to go see a person who can look at that thing, that kind of thing.
Yeah, I mean, ultimately, the way an emergency physician thinks about the world and their patients and their role is, number one, is this person having an emergency? Number two, can I figure out their dispo? Do I need to admit them? And sometimes, Roy, from just somebody walking through the door, I can immediately already tell you if they're going to be admitted or not.
Yeah, somebody told me that there was this line that like the patient diagnoses themselves in the first 30 seconds. I don't know if that's a thing that doctors actually say.
The patient will give you the answer if you listen to them. That's the other problem, is doctors often don't listen. And then, after you've decided if they have an emergency and if they need to be hospitalized, then you're really focusing on like, hey, how can I help this person? So if they have a migraine, almost no migraines need to stay in the hospital as long as you're sure they have a migraine. And so I can just give them some medicines through an IV, and about 90% of the time, their migraine goes away within a few hours, and I send them home. But ultimately, the threshold is, are you having an emergency? Because could I technically do a workup for your lower back pain that's hurt for 3 years? I technically could. Is that an appropriate use of emergency services and emergency imaging? It's usually not. And so I will do my best to help the patient with their pain, their symptoms, whatever it is, and I'll try to get them on the right track to a referral to see the right specialist or a referral to get an MRI. But often I'm not doing every single test in the book in the ER because I already know they don't have something that is ultimately an emergency for me to respond to.
How long are you typically spending with a patient? I could imagine there's a world in which you have a clock ticking in the back of your head and you're trying to move as fast as you can on to the next patient and balance that obviously with the duty of care.
That's a really interesting question because the amount of time I'm spending with a patient is a mixture of how sick they are, how confusing their symptoms are to me, how much free time I have, generally speaking. And I'm actually also, I don't think many patients understand this about ER doctors. I'm also trying to balance the future patients who may be showing up in the next couple hours, who I
Sure.
actually am going to need to spend a lot of time with, who have a
Sure.
have
You're
an,
trying
who
to keep some
truly
slack
have an
in the
emergency.
system in case somebody comes in, like going through a life-threatening crisis.
Exactly. Or I know that there's 20 patients in my waiting room, and I'm looking through all those patients and seeing what their chief complaints are and what their vital signs are. I'm making a decision. Hey, I understand that you've had lower back pain for 3 years. I'm going to work on your pain, but I'm not going to do every single test in the book here because I need this bed for somebody who could die tonight, essentially.
Oh, it's an emergency. And I realize there's enormous range. So I'm just trying to get a sense of how much are things the same versus different. A typical stop by with a patient in those circumstances is 2 minutes, 20 minutes.
The other beauty of emergency medicine is I get to always keep checking in with my patient. In the clinic, you see the patient and then you guys come up with a plan and then the patient disappears. Versus in the ER, I can check in and say, hey, oh, your pain's better. Great. Well, I'm going to work on.
You can be a little more fluid. You can talk to them for a few minutes, leave and come back. My guess is the time spent may even depend on the physical configuration of where they are, which rooms they're in compared to each other, that kind of.
Or if they're in a room at all, if they're in a hallway and I need to move them to a room to do a more private type of examination or talk with them about something. So I would say generally the initial interaction is probably between 3 and 8 minutes, maybe in the room with the patient. And that's taking a history, examining them, telling them the plan, finding the nurse and saying, okay, yeah, we're going to draw some labs and stuff like that. And then, a check-in could be poke your head in around the curtain for 30 seconds and see that the patient's feeling better and smiling, or poke your head in and see they're sleeping. Hey, I do not want to sleep. I don't want to awake the sleeping migraine patient. That usually means they're going to be better by the time they wake up. Or it could be, oh, wow, you're not better at all. Okay, we got to change the plan here. Wow, I really thought that the breathing treatment I was going to give you was massively going to turn you around and you were going to be ready to go. Oh, you're feeling worse than when you came in? Okay, we're going to do labs. We're going to do an x-ray. I'm going to start you on different medicines. Now, maybe I'm wrong. Do I have the wrong diagnosis in my head? Maybe we have to now keep you in the hospital. So fluid is the exact right word. It could be that I see you initially for 2 minutes and then I get called away to a stroke. They say, Dr. Walker to room 26. And so it's very fluid. It's very dynamic. It's often not predictable at all.
One of the things I'm curious about in those pressured environments is how professionals integrate different things they have to achieve at the same time that may be in tension with each other, if only just a tension, which is to say connecting with the patient and providing, let's just call it the medical side of their care. Not that connection cannot be a form of care, but one of the readings that you recommended was How Doctors Think. And I was struck by that, the Salem's Challenge, which I mentioned earlier, which is, there are physicians who everybody in the hospital loves and every patient thinks is giving them great care, but who in fact have terrible clinical outcomes, that they're clinically incompetent. My guess is the reverse is also true.
Yeah.
And so when you are providing care, how do you think about the patient's experience of you and your connection with them?
I know exactly what you're talking about. The first impression is everything, especially in emergency medicine, right? People are coming in pain. I never see anybody that's like happy to see me. Never.
Yeah, sure. Well, hold on. They're not happy to be there, but having been in the emergency room, they're very happy once the doctor walks in.
That's fair.
Sometimes they're relieved is maybe the right word. and maybe they're ready to pounce on you with all their like, hey, here's what's going on. And my Uncle Carol had this too, kind of thing. But there's certainly some kind of a positive response to the doctor.
I would say one of the key soft skills required of an emergency physician is the ability to gain rapport within 15 seconds. No one's perfect. I think I'm pretty good at this, but like reading the room, reading the patient's face, and generally speaking, the way I should present myself as their physician is super casual and chill, or extremely professional and, by the book. And because there are patients that will view the chillness as I'm not taking them seriously. And there's other patients that will view the chillness as like, oh, this guy's confident. This guy knows what he's doing. He's going to be able to help me. He's actually helping me reduce my anxiety or my worry, and vice versa. And so knowing how to talk to the patient, how to speak, how to carry yourself, do I, kind of jokingly scoot them over so I can sit on the bed with them and talk with them? Will they think that's like a very familiar, ingratiating, kind thing to be? Or will that be like, well, who is this guy thinking? Get your own chair. So knowing how to gain that rapport immediately, to gain their trust, to get them to tell you the right story is critically important. It's maybe one of the most important things that you have to know how to do.
The thing that strikes me as you describe that is the range of people you see. It strikes me that it's possible that a hospital emergency room is one of the few places remaining in our world that everybody has to go through in the same way. It doesn't matter rich, poor, insurance, not, color of your skin. You are going, maybe what neighborhood you're in may differ and the nature of the hospital may differ, but like anybody can walk into that room. And so is that right? And how does the range of life experiences, people who don't speak English? I don't know, like give me a sense of how wide the aperture is of the range of people that you are trying to build rapport with.
I can see a 1-day-old infant that was just discharged from the hospital 10 minutes ago, to I think the oldest person I think I've taken care of, I think she was 112.
Wow.
And so, yeah, pregnant, not pregnant. Every range. You can walk into an ER with any chief complaint, which is just, the way that we talk about what a patient's issue is. And I have to figure out, what the heck am I going to do with you? The example I like to give is in residency, it's just amazing what humans can do. I know a young woman who had been drinking the night before and came home and was just a little drunk, and I think thought that there was some juice on the counter and drank it and went to bed and woke up the next morning and realized that she had drank an entire bottle of Suave peach conditioner, like hair conditioner.
Okay. She's like, is this going to be a problem or not?
Yeah. So she was coming in like, hey, I think I was really drunk last night and this bottle is empty. I think I chugged this hair conditioner, and, that's not in the textbooks of what to do. So, but again, getting back to knowing how to solve problems and knowing how to learn, I called our toxicologist on call, and luckily conditioner is inert, and he kind of laughed and said, yeah, she'll just poop it out and she'll have like a really soft poop. but like, it is amazing. Just when I think I've seen it all, I have not seen it all. I'll never forget this. Like a year ago, it was like a SLOW, like a nice easy shift morning, I think on like a Sunday morning.
Do doctors have lots of superstitions?
Oh, yes, very much so.
By the way, as you were talking, I was like, is the woman drinking too much and drinking the conditioner? Was she 112 years old, or is that a different person?
Different woman.
That's all right. Keep going.
Yeah. So this guy comes in and says he thinks he was having some really severe side pain. And he thought it was from when he was shot like 13 years ago. He thought there was an infection from where he had a chest tube in. And a chest tube is a tube that we put in the thorax to open up a lung that's collapsed, and because he was shot in the chest. And he survived and he was fine. And it turns out they left the bullet in, which we often do if it's not in an area that's easy to get to, because you don't want to dig through and
You can cause more damage getting it out than leaving it in.
and what had turned out was he'd been shot in his shoulder, and over 13 years, the bullet actually migrated down to his armpit area, and it was his body was trying to push it out. And so I said, I don't think this is the chest tube. I think this is the bullet. And he said, no, 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 I was shot in the shoulder. And I said, no, I think gravity in your body has found a track to get it out. So I said, hey, can I numb you up and
Get out the bullet?
yeah, and I ultrasound. I did a chest X-ray, and I was like, "That is exactly where the bullet is." And so I numbed him up, and I mean, I felt like Excalibur pulling this thing out. And I had one of the nurses record it, obviously with the patient's permission, on his phone. But I pulled out a, I don't know, 9 millimeter, whatever the caliber is. I pulled it out of this guy, and just immediately like, oh, he immediately felt better. He had a little pus around that, so I put him on some antibiotics and sent him home 20 minutes later. But like, talk about changing this guy's life. I think he had seen one of the surgeons, and they said, "Oh, I don't really want to take it out.
He's not going to beep going through the metal detector at the airport anymore."
Yeah, totally. And I like pulled this bullet out of this guy. I'd been an ear doctor for 17 years. I've never done that before. And I was like, hey, this makes sense. I'll just numb you up and let's take care of this for you.
And so people whose life experiences are very different from yours, I'm going to assume you've never been shot.
Nope.
But just, even like socioeconomic class, race. I mean, here we are, two white guys talking to each other about this.
Yeah.
Gender, age, culture, geography. How do all those factor in to how you think about relating to a patient? Because on some level, they're all human bodies. And so they have common functioning in many ways. So one could have a view of like, I don't care. If I got to get the bullet out, I got to get the bullet out. But how does the difference in who the person is affect you?
Yeah, I mean, the cultural piece is massive. One of my med school professors told me one of the best questions to always ask every patient is, hey, what's your level of education? And there's ways to ask that in ways that don't sound, I think some people that can sound judgmental, but getting a sense for what the patient understands about their body and what the point of their medicines are, and how they live their life is extremely helpful in how you're going to talk to them about their body and their conditions and things like that too. You're not going to talk with somebody that has a third grade reading level the same way you're going to talk with somebody that's also a doctor or is a PhD in, mathematics or something like that. Or you're just going to have a different language and approach to them. And sometimes you can read people like, sorry, engineers, but you guys stick out like a sore thumb. I love having engineers as patients, but they're so obvious because they're very meticulous. They're very detail oriented. They often have like a, by the minute breakdown of their symptoms, and have given some thought as to what could be going on in their bodies too.
Have there been cases where you misread something or missed, and so like where the nature of how the person approached it would have been critical to know, or something about their assumptions would have been helpful to know, help us understand, the learning from the glitches?
The glitch that I think everybody in healthcare, everybody has done once and hopefully has never done again is, assume who the other person in the room is. So, your daughter tells me that you've been having chest pain. That's my wife.
Yeah.
Oh, well, I'm not gonna recover from that one before. And so, we all have ways of, oh, who did you bring you with you today? Or, oh, what's your relationship? It's so great to meet you. So yeah, there are absolutely faux pas. And then, on the flip side, when you are a patient yourself as a physician, there's always this like debate in your head, like, do I tell this person that I'm a doctor? Like, do I want to be a secret shopper and see if they really know what they're talking about? Or is it going to get too uncomfortable for me? Like, many healthcare professionals will intentionally use medical verbiage when we're talking with our doctor or our nurse.
To hint to them so that they're aware of your level of knowledge.
Like, hey, doctor, thank you so much for seeing me. I've been febrile for the past 3 nights, and I've got a productive cough, and I've got some pleuritic chest pain.
Right. And you're like, okay, I get it now.
Yeah, it's giving away the secret.
It's like, here's my pad. Write your own prescription.
Yeah. It is challenging sometimes when the doctor hasn't done that and you're speaking to them at a particular level and then they say, "Oh, I'm a doctor." Yeah, yeah. Okay. Well, what do you think we should do?
It seems like a lot of the job is likely repetitive.
I thought it wouldn't be. Yeah, I thought emergency medicine, there's no way it's going to get boring or repetitive, but yeah.
Well, and look, sometimes repetitive things are boring and sometimes they're not. Lots of people crochet and, the repetition is meditative instead of being a chef is repetitive in certain ways. So, but I get that it can be boring. I think what I'm curious about is how often do you feel like you have situations arise that are really new?
I think the universe has a way of keeping doctors humble.
All of us.
All of us for sure. Yeah. I mean, that just medicine will do it to you in a medical way. The minute that you feel you're starting to get cocky or on your high horse, that you're just a really good doctor and you know everything, the human body and biology will humble you. The thing that you thought for sure, well, you can't have sepsis and come in with an ankle sprain. That doesn't make sense. It can. Like the universe will humble you and put you in your place for sure. That's why I think it's critical to be very humble and respect
The
the
unknown.
power of the human body and the frailty of the human body as well. Yeah, the world will absolutely challenge you.
I feel like I read this phrase maybe in your blog and maybe in one of the other readings about the what do I do now moment of like, sort of like, I haven't seen this and I'm not sure what to do. And my guess is those happen a lot earlier in your career and maybe less often with time. But, sometimes we assume we know what we're doing and we mess it up anyway. And so I guess I'm curious about how often, what kinds of novelty are you experiencing and how often?
Less and less frequently with time, but certainly, you know, certainly once a month, there's something that's like, huh, I haven't seen it explained in that way, or oh, somebody hasn't said it that way to me. I had a physician patient just a couple months ago who, God, what did she say? She said when she was breathing while she was sleeping, she was making weird sounds. And this is a doctor, and I was just like, I remember telling her, I don't know what that means. I've never heard that before.
And also, how does she know what sounds she's making while she's sleeping? But anyway, let's continue.
Yeah, it was very confusing to me. But I said, "Oh, she's a physician. Yeah, okay, let's think through this." And so I asked a bunch more questions, and ultimately, she was diagnosed with like a really serious problem. She had a blood clot in her lungs. People will describe things differently. People will have symptoms that don't seemingly go together. That's the other reason I really like emergency medicine is there's always at least two doctors on shift with us, at least at my hospital. And so you can always we call it curbsiding, meaning you can ask one of your buddies, one of your colleagues, like, did I miss this day in med school where people have tooth itching and they're actually having a heart attack or something weird like that? So I would say it's not common, but it does happen. Where this kind of looks like one thing, but it also looks like something else. There are often people who have symptoms that overlap with two very different diseases. Normally appendicitis is like a slow, gradual onset of worsening pain that kind of over maybe 6 to 12 hours localizes, meaning it like finds one spot that really hurts in your abdomen where your appendix is inflamed. And then versus a kidney stone is usually boom, all of a sudden pain, really severe, radiating to your back or down into your testicles or your groin. And those are two very different diseases with two very different treatments, of course. And there are often patients who have appendicitis and they swear their pain came on suddenly. And there are people that have had a kidney stone for 3 days and you think there's no way this person has a kidney stone.
Are there common patterns that doctors know about of like, every day you're going to have one of these or things that patients often miss? Like, what are some of the common, if everybody saw the world the way an doctor sees the world, what are the things we would know are more frequent than we realize?
There's this concept of type 1 and type 2 thinking. Type 1 is kind of rapid pattern recognition, its heuristics. And then there's type 2 thinking, which is like slow, methodical. Most of emergency medicine at least starts with type 1 thinking. And that is there a common pattern to this patient's symptoms? And even one step more removed, Roy, is the concept of what we call sick or not sick. And that is something that you learn in med school and in residency. And that concept is, when we say the word sick, we mean there is a look to human beings when they have something very seriously wrong with them. And seriously wrong being the definition for that is like, hey, this person has something that they might die of in the next, let's say, 24 hours if I don't figure it out. It's hard to put your finger on sick. It's one of those you know it when you see it type things, and it is a gestalt amalgamation of all the different sensory inputs you're getting in your brain, and it's probably a mixture of the color of the person's skin. Do they look pale, or do they look jaundiced, or do they look ashen or gray in color, or green? Honestly, what is their breathing doing? We're really bad at counting respiratory rates in the hospital, but you can very easily tell how someone is breathing, and how they are breathing is likely the most predictive measure of if somebody is going to be critically ill or not. Obviously, not only because we need oxygen, but we also need to get rid of carbon dioxide, number 2. And then number 3, we can also get rid of acid that's building up in our blood if we breathe faster as well.
And so there's this sort of like immediate, are you sick or are you not? If a person is sick, do you treat them differently? Meaning, are you like, well, I couldn't figure out the thing, but I know there's got to be something, so I'm just going to run some more tests, or I don't even know what.
Absolutely. In fact, when you're working with, say, an intern, if I'm supervising an intern and an intern has gone off to see a patient, the first question I will ask them is sick or not sick? And they intrinsically know what that means, what I want from them. Because if they say sick, I actually will stand up and say, let's go talk at the bedside, because now I want to see that person and see if they they do look sick.
Are people good at assessing that? Like, is somebody who's been an intern? So it's something that once you pay attention to it, it maybe not reliable, but it's a common indicator.
One of the key skills that I think you need to have by the end of your intern year is know sick versus not sick. That's like a key thing, I would say, for every specialty outside of pathology where, the patients are already dead.
Yeah, right. Pathology, they're dead. Right.
So yeah, sick or not sick is a sense of, and it's also, I guess the other thing would be mental status, meaning, are they awake and interactive and talking with you? Are their eyes closed? Do their eyes open when you talk with them? Some people's eyes don't even open unless you pinch them really hard, like you hurt them, like you rub their sternum, or you push a pen against their fingernail, which is really painful. So that's a general sense of sick or not sick. So yeah, a ton of emergency medicine is pattern recognition. And then I would say not uncommonly, we get to a point where we're like, oh, abort, patterns are not patterning. This is not fitting into one of my boxes. And, as an ER doctor for 17 years, I probably have 50 or 100 boxes. Like, I've built up boxes over time when I've seen a fairly rare thing. Oh, I've seen it a few times now. Well, I got a box for that now. But once it's like not fit into a box, then we kind of go back to type 2 thinking. And we say, okay, let's methodically go through the list of problems this could be. In the ER, we'll do like a little, I don't think it's a game, but it's a way to force our brains to get into type 2 thinking. And so I'll ask a resident, okay, what do they most likely have? Like, what's the most common thing they probably have? Like, let's be honest, they probably have gallstones. What's a weird thing that they could have? Oh, it's not gallstones, it's a gallbladder tumor. Something rare that maybe I'll see a few times in my career. And we call that a zebra. We call that, I'll tell you why in a second. And then the third thing is, especially for the ER, what can't I miss? If they have this and I send them home, they will die. And so we use that We use those three questions to force our brains out of pattern mode and force them to go into a different mode.
I love that.
So there's a saying in medicine: when you hear horse hooves, think of horses, not zebras. Meaning, most patients, most of the time, have common stuff. They don't have
Right.
rare stuff. You cannot work up and evaluate every single patient with a cough with a CT scan in case one of them has a lung cancer.
Right. You're making rough judgments about probabilities because you have to deploy resources that cost the hospital money and time, and you can only do so many of them and may prevent another patient in more need from accessing that.
And there's risk. There's risk to doing a CAT scan on every single person that doesn't need it too. You're probably going to create at least a few dozen cancers if you do it on every single person.
Do CAT scans give you cancer?
There is a theoretical risk, and this is all from studies from the bombings in Japan. There's a theoretical risk of radiation exposure increasing your likelihood of developing a future cancer. It got some. There was a study that got a bunch of news in the past month or so that kind of quantified it a bit further. But again, it's all based on theoretical studies.
But understood that every intervention also, even a test, is an intervention that may affect the trajectory of the patient's health, sometimes for the worse.
The thing you learn in medicine is there is pros and cons and benefits and risks to everything. There is not a free lunch. There is nothing that you get without risk. Even something as simple as an IV. Now, 99.999% of IVs have no complications. They're safe almost always, but sometimes you can get an infection from an IV. You can get a blood clot in your arm from having an IV in. And so physicians are always trying to optimize that balance. And so I think often patients will, be frustrated if we don't want to do a particular test, or we want to do this test, not that one. But ultimately, a good physician is always trying to optimize that risk benefit analysis.
It seems like there's something common here between physicians and investors and poker players of decision making under uncertainty.
Yeah.
And there's an intellectual side of that, sort of how do I trick my brain to get out of this so that I can be in a better frame of mind? There's also an emotional side of that decision making. And so I'm curious, in an environment that is emotionally alive, as we talked about before, we talked earlier about how do you kind of plug into the emotional side to have connection with another human being and empathy and awareness and all that. Can the emotions interfere with the decision making?
I'll sometimes have patients that look like my grandma, and I'm, or they look like that's an Asian version of my Nana.
And so do you take extra good care of them, or is that like, grandma, you shouldn't have been so mean to me back then?
It kind of gets you out of your doctor mode a little bit. And it's like, whoa, it short circuits you and makes you, in some ways, I think for really good reasons, it makes you think of this person as a human because you have a familiar association with this person. I'll tell you the other way that I think we actually have, doctors have found even a way to use our emotion to get back to medicine, and a little bit to kind of trigger that primordial amygdala gestalt thinking that sometimes is really hard to get at when you've gone to type 2 thinking. Sometimes it's helpful to get your gut instinct about stuff. And so one of the things we will say to each other is, if you don't do this test, are you going to go home and worry about the patient that night? Or you're going to lose sleep because you didn't do the lumbar puncture or the CAT scan or whatever. And that's a way to use that emotional primal thing of how worried are you really about this? And then obviously the reply, the call and response to that is, yeah, if you're worried about it enough that you're going to lose sleep over it, you should just do the test.
In that case, the emotion is a positive clue sometimes for decision making.
We have found a way to harness the emotion to actually help us make better, hopefully better decisions.
Do the superstitions help with decision making?
It helps us to blame the med student if they say the Q word, QUIET, or the B word, BUSY. Like if a med student walks in and says that, we get to blame them for,
Yeah.
oh, Stephen, what did you do? Even if you can have we love to, blame someone for the misery of the ER being busy. And so, even if you can have a wonderful shift and 9 of the 10 hours are perfect, that last hour, see, I told you, Stephen, you did it. You ruined it for us.
I love that. Okay. So another thing that comes up for me, and maybe this is the moment where we can get to it when we talk about quality of decision making, is the use of technology. As an AI investor, there's a case to be made that there are some circumstances. I'm not going to claim AIs generally make better decisions than humans. I don't think anything is quite that simple. But I do think that once you have a system sufficiently well trained to perform at a level that on average exceeds that of a human being doing the same task, let's say like a self-driving car now, there's a case to be made that removing the human biases, including emotional bias, memory, availability, heuristic, all the ways human thinking is limited, might make for better decisions. And so, some of the younger doctors might think they're like in the ChatGPT generation of doctors. I was in a group chat yesterday where somebody was saying that their doctor admitted to privately pasting images into ChatGPT, probably illegal, and getting diagnostic input. What role, we'll do technology in a bunch of ways, but let's just focus on AI for a second. What role does AI play in making any of these better today?
So first I'll say, I hope, and I actually think there is a world where AI is less biased than the average doctor, the average human, let's say. Now, other people would argue that because AI is just trained and based on human knowledge, that it is going to be biased. And in fact, I think we should be looking for bias and not just saying, oh, we hope it's not there, but like, hey, let's.
By the way, I assume AI is biased. The question just is, on average, is it less? Does it make better decisions on average?
I completely agree. I think there's absolutely a world where AI helps us make better decisions and be less biased in things that shouldn't matter, like someone's race or ethnicity or culture or what language they speak or sexual orientation or anything like that, and more biased or more discriminatory when it comes to like actually finding the needle in the haystack more frequently. I think there is tremendous opportunity. I'll give you an example. There are tools that exist mostly in the research space still today that can predict someone's kidney function or their electrolyte abnormalities from an EKG, which is a 12 lead tracing of the electrical pattern of your heart, the electrical activity of your heart. Now, the reason this is crazy is most physicians, myself included, don't really think of the electrical activity of the heart as having any connection whatsoever to your kidneys. Any whatsoever. Like, it is measuring what's going on with your heart.
Fascinating.
Your heart is not attached to your kidneys. They're far away structures. How the hell could an EKG predict if you have kidney disease? So this, it brings up this idea that there actually is plenty of data and plenty of information, and we are actually reaching the limits of human cognition and recognition to actually use that data effectively. And that's where I think AI is particularly exciting. Like, we don't need a new blood test. We could just do an EKG on you and build a better mousetrap to find the people with chronic kidney disease.
I buy that that pattern data can discover unexpected patterns. That makes a lot of sense. We can think of 1,000 kinds of biases. There's probably 2 doctors with the same specialty who tend to, on average, prefer different diagnoses for different reasons. And one of them might be right and one of them might be wrong, and all that. And I also want to sidestep the whole question of whether the paradigm of Western medicine of being able to concretely identify diseases is correct or whatever, blah, blah, blah. Let's set that aside. How has technology changed the way you doctor over the course of your career? Like, what's the most significant? I once asked this to a group of truck drivers a few years ago. I said, what's the most significant technology that affected your careers? And I thought they were going to say, like, I don't know, something about some road safety thing, or it was Netflix because it just made their lives less boring when they were waiting. And then after that, it was Google Calendar for scheduling. And so the answers can often be surprising. And I guess I imagine all these like complex, bespoke pieces of software for electronic medical records. And every time I see a doctor pull up a screen, it seems like, oh my God, that looks like the worst designed software I've ever seen. How has technology changed or benefited, if it has benefited, your practice of medicine over the course of your career?
That's such a great question. I don't think anybody's ever asked me that. So I am in the in between generation as an elder millennial, where when I was in med school, all of my charts that I wrote were paper, and I would carry around big sheets of 8.5 by 11 paper in my white coat and fold them in half, and I would slowly throughout the day update the plan and stuff from what the attending was saying. One of the big changes is certainly the EHR. We could have a whole other podcast on what I like and
EHR
dislike
is
about
the electronic
EHRs.
health record.
Electronic health record. And so that's, Epic or Cerner, or Athena.
But it's basically the patient having a single record of their medical interactions with you, at least with respect to that hospital or that medical system.
Yeah. And I mean, that's certainly one of the limitations is I can't easily see every single other hospital's records. And so patients, who are visiting San Francisco,
or even every other Epic client's records at other hospitals. Yeah.
But the alternative, which I practice in these days as well, the alternative is calling a human and saying, "Hey, Mr. Jones, medical record 1 2 3 4 5 6 7 is here. I need his chart." And having a stack that is as tall as my desk here, it's like, it's 2 feet high of all of their last hospitalizations and all their prior EKGs and all their lab data and their discharge summaries. And while seeing other patients in the ER, having to, as quickly but as thoroughly as possible, scan through all that information and find the maybe one key piece of information that I'm looking for that's in the third chart on page 7, upside down.
Right.
And now most of the time is available to me. I'll tell you, I'll give you another example of how this is really helpful.
By the way, when you enter things in now, do you type or do you talk?
I mostly dictate, but sometimes I type because I'm a pretty fast typist too.
Yeah, okay. But you mostly dictate and it gets transcribed. By the way, Perplexity says that the reason that we call it a chart is historical because there oftentimes were actual charts alongside the narrative notes that people had.
Oh,
I
fascinating.
don't know what those charts were of, but who knows? Anyway, mystery quasi solved, not fully solved by the AI. Transcribing versus versus typing, and so you can get the information in that way. But you're saying that it is the availability of a digital health record that is the single biggest change in your practice of medicine since you began.
I think so. I'll give you another 2 examples of how it's really helpful. Humans come in different shapes and sizes, and there are different thresholds and cutoffs for normal and abnormal. Whether it is some things are cut and dry, right? A potassium level of 7 is never normal, but what your EKG looks like or what your chest X-ray looks like, there's some variation there in what's normal and what we accept as, that's a normal variant. We call normal variant a lot. Like, oh yeah, some people are born with this extra tendon called the palmaris longus tendon in their wrist, and many other people aren't. And some people's EKGs look a certain kind of way that in the right setting could be abnormal. And so there's a lot of interpretation. But the point I'm making is that the electronic health record lets me find your old EKG or your old chest X-ray.
So you can see if this is normal for you.
This is normal for you. Oh, they have always, every single chest X-ray for the past 3 years has had that little thing in the lower right side of it. So that's definitely not pneumonia today, even though they're coming in with a cough today. That's always been there. Or, oh, they're coming in with chest pain today. Oh, whenever their heart rate goes fast, their EKG looks like this. And so I'm going to treat things in a different way, or I'm going to be more or less concerned because I've got your old EKG and I know what quote unquote normal is for you.
Explain this one to me. Every time I've been through a medical system, it feels like each medical practitioner I speak with, I need to start from the beginning and explain the whole thing. Is that because I don't trust that they actually know, or because despite the availability of this electronic health record, like in a world of paper charts, I get it. Like you don't have time to read through all that stuff. The doctor or the nurse doesn't have time to explain everything to you about each patient. It's just as easy for me, the patient, or the husband of the patient, to explain the thing. But in a world of electronic health records, I'd like to think that the second you walk in the room, you have the benefit of the prior conversations in history. And yet it doesn't always feel that way. And so help me understand why that is.
I got two answers, and they're both, I think, equally important and equally correct. Number one, the first answer is medical culture, in that you trust no one else but yourself. If you didn't do it, it ultimately, and that comes back to like,
Sorry, so that's the physician not trusting anybody but themselves, or the nurse, or whoever's coming in.
you cannot trust someone else to do your job or collect the history. There's a fundamental responsibility that, like, eventually, as the attending, the buck stops with you, and you better get it right. And so that's kind of a sense of ownership and responsibility that I think gets taken to the extreme degree.
And I also think there's something, as a patient, I've recognized this, where it's like, if I have to re-explain it again and again, the chance that if I got something wrong or they misheard something, like just more shots on goal for getting to the truth.
That is a perfect segue to reason number two. And reason number two, we call the attending effect.
Okay.
And that means that when the resident went in the room and took the history, the patient said, yeah, I've definitely never had a fever. And then the attending goes in and says, hey, I'm Dr. Walker. Just wanted to check in with you. I hear that you've never had a fever. What do you mean? No, I've had a fever for 3 days. And it happens to all of us. I cannot explain the patient psychology of why it happens, but residents will always apologize. And it's like, look, I was a resident too. This happened to me. Patients will change their story entirely. And it even happens from triage to when I see them in the room. The triage nurse can 60 seconds earlier, the patient could tell the triage nurse, 5 days of right-sided abdominal pain with vomiting. Not 60 seconds later, I walk in the room. Hey, I'm Dr. Walker. I hear you're having some right-sided pain. Right-sided? No, it's on my left. What are you guys, idiots? And so it changes very frequently. And so that gets back a little bit to the first point of I have to go by what the patient directly told me, because the stories sometimes change.
And also the bias, if they came in and said XYZ, you're much more likely to repeat it. I've noticed in different situations also, as a patient, I just feel more comfortable with one person versus another. The same way you have the doctor's bias, the patient has the bias too. Of I don't know, this person looks like my grandma, so I'll be more likely to open up to her. Whereas that person has unkind eyes, and therefore I don't want to tell him what's going on because I don't, it seemed like he had an argument with that other doctor, and I want her to win or whatever. We all have human biases on these things.
You're absolutely right. And the other challenge of being a physician, and shout out to my incredible emergency nurse colleagues, patients really want to please the doctor. And so patients are way, way, way more likely to skirt around the truth of how they're maybe really feeling because they want the doctor to be happy, versus they will be way more honest with the nurse. And so sometimes I'll get a little vibe that hey, there seems like there's something else going on in that room that I asked them 5 different ways from Sunday, about this. And they claim there's nothing else going on. Can you go in there and just while you're putting in the IV, just ask them the same question about their living situation or when they last had sex or, whatever it is. The other thing is true where I will go check in with the patient and they say, oh, I'm feeling better. and start writing their discharge papers. And the nurse is literally 60 seconds later, the nurse is like, hey, they say they're still in pain, or hey, they say they're still vomiting. And it's like, what do you mean? I was just in there. And so we know that's just a thing.
Fascinating.
It would be silly not to, you can't get mad at people for it. You just have to be like, oh yeah, they're trying to please the doctor.
You're segueing into something that I know we want to talk about, which is the team, and working with the team. But let me just ask before that, just still on technology for a half second. If a doctor says, how do I get good at using technology? There's a temptation that I would have to be like, well, you can only use the stuff that's legal because it has to have HIPAA compliance, which for folks who don't know is about, federal legislation, federal law about protecting the privacy of your medical data. And therefore, it's not like going rogue as a venture capitalist where it's like, I could use what software I want. It's not going to create a security problem unless I'm really sloppy about it. Famous last words. And I know doctors cheat and use things that are illegal. And so what's the right, obviously you have always obeyed the law, but what is the right way to think about how a physician ought to engage in experimentation with new tools?
I think you said it right there. I always recommend that physicians just try out these tools without real patient data. And in fact, AI can make fake patients for you and fake patient scenarios to make it really easy. I just this morning did a screencast that I'm going to post tomorrow about MedGemma, which is Google's new medical AI model that they're kind of open releasing for commercial purposes even. And really my takeaway from that is I'm trying to teach doctors how to just install the tool and use it, because you learn so much from the act of experimenting. And oh, hey, I'll give it this chest x-ray with this prompt and I want to see how it works. Oh, it did really well with this one. Well, why did it suck at a CT scan, but it was really good with a chest x-ray? What's different about those two things? And how is this going to impact how I'm going to use this in the future? Oh, this could be really helpful as a second set of eyes, but I'm never going to rely on it to be my primary source of truth or something like that. So experimentation, trying out these tools is extremely important. So plugging off call here, we have a webinar where it's myself and my friend and AI expert, Dr. Sarah Gebauer, and we're just going to do AI basics for physicians. We're going to say
Awesome.
what is AI? How do you get it comfortable with AI? What are the different types of AI? And we're going to use all healthcare examples so that it's really easy for doctors, nurses, pharmacists to understand.
And presumably, I'd not tracked the medical Google model, so that's helpful to know about. Presumably, there's then some evolution for some tools where they go from personal experimentation by the physician to the clinic, the hospital, the something embraces the thing. Obviously, if you have your own medical practice, that's easier because you could just decide for yourself. But what does that process look like?
It is you're describing governance, as we call it, and it's a big challenge. I think health systems want their physicians to use the best technology, whether that's an EHR or an iPhone or a CAT scan or AI, but they also want their physicians to understand the risks and the benefits and make it safe.
And they want consistency in different physicians. They believe different technologies are different. There's cost for some of these technologies.
Yeah, I mean, the governance challenge is huge because there is certainly a risk to AI. The thing that I always like to point out is that there's also risk to not using AI. There's risk to having patients wait 4 months for an appointment. That has consequences as well. So I think health systems need to think about risks globally and not just think, oh yeah, if we deploy AI, these bad things could happen. Of course they could, but bad things are already happening because we don't have the access or the appointment availability that we need to take care of patients too. The only other technology that came to mind when I thought about the most transformative is the iPhone or a smartphone. Just being able to have a device that allows me to send pictures, send text information.
Do physicians use two phones like drug dealers and spies?
I got my second phone here somewhere. Yeah, going from pagers to phones dramatically improved the communication capabilities of doctors.
Right. Because I always used to remember being like out for dinner with a doctor and they'd get paged and then they'd have to go away and talk for a few minutes and come back. Versus now, my guess is you're also more accessible as a physician, but that you could just text the person back and say, nah, just, give them some more CCs of something or other.
Yeah, the ability to triage those messages. We used to use little secret codes. So if you sent a pager number and then star 911, that was a way that hey, drop everything, call me back. Versus now, I can send you a secure text message. I can give you the whole rundown. I can say, hey, Dr. Urologist, I've got a guy with a 6 millimeter proximal kidney stone and he's got a fever. So I think he probably needs to get a percutaneous drain that drains the urine out of his kidney. Do you agree? And I'm going to start him on some antibiotics and admit him to the hospital.
So you described medicine as a team sport. I definitely get that because I've seen the TV shows and been treated by a team and all that. But you also described the patient as part of the team. And it seems like patients and their own advocacy, let's just start there, is a huge variable of how does patients must get treated differently based on their own advocacy, even though in theory they shouldn't, I don't think. How does the patient and do patients hire people sometimes these days? I don't know, I've heard of a thing called a medical concierge. I don't know if doctors ever deal with that. Patient and family and friends, tell me about that side of the team and what it's like.
I think always the more engaged patient is always preferred over the, frankly, not engaged patient.
And there are people who are disengaged in their own health, which always surprises me, but I believe it. I've seen it.
Some people will even say, don't care about the patient more than they care about themselves, or you can't
want it for them is the expression I've heard in business.
It's frustrating when you try to ask a patient what meds they're taking and they say, oh, it's in the computer. Well, I looked in the computer. I want to know what you're actually taking. I understand why patients get annoyed with I've already told 2 people my story. Why are you also asking? Well, I'm the doctor. I'm really sorry. You got to tell me too. So I think generally it's better for patients to be, we like people that are more engaged. And I always try to acknowledge, again, to try to gain rapport, acknowledge the family member or the loved one who is the advocate there and say, I'm so glad that your husband has you to help support him or whatever, because it's really the advocate wants to be part of the conversation as well.
Yeah, I remember, by the way, when my wife was giving birth, I think to our first, and, it's she's a little out of it. And so understandably, she's under the influence of some fairly powerful medicines. And so my job was to remind, sort of do the 30-second spiel when a new person came in about what had happened. But then I remember being and by the way, I've got a headache. Can you give me some Advil? And they're like, no, we can't. You are not the patient. And I was like, what? Blew my mind. It kind of made sense, but to the point of wanting to be included.
Yeah. No, I think it's really important that some patients aren't good at advocating for themselves. Others aren't able to. It's really important that patients have advocates that can help them and help them sometimes frame their information more clearly. The most stereotypical thing that happens not uncommonly in the ER is, of course, the husband that is dragged into the ER by the wife and just says there's something wrong with him, or hey, he never complains and he's complaining now,
but we don't know what it is.
Yeah, we know what it is. Or sometimes it's my grandma hates the hospital, but she told me I want to go to the hospital.
Yeah, I've got an uncle like that.
Yeah, or the running joke is the farmer. If there's a farmer that shows up in the ER, call the ICU.
Everything's on fire.
Yeah, call the ICU. They're having something terrible because farmers, their arm is falling off before they come into the ER.
Are there forms of advocacy that can be problematic?
The challenge that a lot of patients have is, even with these larger and larger health systems, I think patients often feel passed from one specialist to another. And sometimes, as an ER doctor, I get stuck in the middle of it. And they say, well, the cardiologist said this yesterday, but we saw the nephrologist 2 days ago and they said something different. And, okay, well, now I'm the decider. I'm in the middle of this. So that can be a challenge because patients often know and trust their cardiologist, their primary care doctor. And so I have to not like dump on the PCP who maybe I disagree that they
Sorry, what's a PCP?
primary care doctor. Yeah. I don't want to like dump on them and say, yeah, I don't think those antibiotics were necessary or something like that. And because what ultimately is often important is the patient and their primary care physician maintaining that relationship of trust. And so that often is a challenge where I'm in the middle and trying to kind of be the peacemaker as well.
And are there patients who bring in others that work for them to advocate on their behalf? I mean, like, is that a thing that patients ought to think about, or is that just a myth that I have heard?
I mean, I have never seen,
and maybe that doesn't happen in the ER either.
Yeah, I think ER especially. I do know the concept of a medical concierge, and I do understand the concept of someone helping you navigate the ridiculously complex, confusing healthcare system. And, well, why am I going to a cardiologist if I have a whatever problem with my liver, whatever it is,
Like that gets to privilege and people who have financial privilege being able to get more. My guess is this is where a lot of bias comes in. I mean, you talked about the wife bringing in the husband. I've been the husband accompanying my wife to the emergency room when she just like sliced her finger on something in the morning. So in that case, it was, so that one was obvious, right? It's like, show them their hand. But my guess is that people and there's probably research that speaks to this, that people who are from backgrounds that tend to be discriminated against more may not even be believed. So like women, people of color, anybody who presents in something other than what the doctor is prepared for. And so is that a risk? And how does one think about that as a physician?
I mean, we even call it atypical chest pain.
What does that mean?
So atypical chest pain means chest pain that isn't crushing and left-sided and a pressure feeling on your chest. We call it atypical. However, the crazy thing, and that model of typical left-sided pressure-like chest pain comes from, like white guys in their 50s having heart attacks.
Meaning atypical may just mean not a white guy in their 50s.
Well, here's the crazy thing. One of the factors, the pain that radiates down the arm, the left arm, everybody thinks that is associated with
heart attacks.
When you actually look at the research, one of the most predictive factors of having a heart attack is chest pain that radiates down the right arm. Medicine decided 70, 80 years ago, the typical stuff that should make you typically worried that this is a cardiac cause of chest pain is, pain radiating down the left arm. Now, pain radiating down the right arm is not common. It's actually very rare to have somebody tell you that. But when they tell you that, they are way more likely that they're having a heart attack. Like when a patient tells me that, they're like, it's so weird. It's going down my right arm. That doesn't make any sense. It's supposed to be left arm. I'm like, oh, crap. This is the real deal.
Oh, wow.
So it's weird. Number one, we call it atypical. And then the other piece that I think is really important to mention about female patients is, and this is a nuanced thing that often gets kind of messed up in the media, is when you look at all female patients are just as likely to have what we would consider typical cardiac chest pain, meaning they have chest pain that's a pressure, lasts 5 to 10 minutes, all the normal stuff that we would see in a male patient as well. That's the number one way that female patients with heart attacks present. But, this is the nuance here, female patients are more likely than male patients to have atypical or less common presentations of how a heart attack can present. So some patients, female more than male, can present with like just profound fatigue. Some patients can just have shortness of breath, no pain at all. Some patients will actually have like upper abdominal pain, not pain in their thorax, it's in their abdomen. And female patients are more likely to have that show up as a heart attack. Now, a male patient can have that too, but overall, it's still the most likely.
Sure, it's just the probability distribution is different.
Correct. Yeah.
And what about biases around literally just not being believed? Like people like sort of dismiss, like my guess is you end up as an ER doctor, and maybe many other physicians get this too, just with folks who are like, nah, there's nothing wrong with you. You're just, I mean, forget about even just like hypochondria, but somebody who thinks there's something wrong, but really it's like, buddy, you just like scraped your knee. And to what extent does that happen that a patient just simply isn't believed, and might that land differently depending on what the background is of the person?
I see this a lot on social media, and there are absolutely patients that don't get believed. I mean, we like literally even have a saying that's like, believe the patient, like listen to the patient. So the patient will tell you what's wrong with them. I think we're at least in the ER, I see a lot of people complaining about the ER didn't do anything for me.
Sure. And my guess, I mean, look, this is like also there's like this element that's like customer service complaints happen all the time. It's like, yeah, they didn't do anything for me because I had some unrealistic expectation. But I know that's not where you're going.
The challenge is, again, the way that I prioritize things is like, are you having an emergency or not? Just because you're having numbness in your leg doesn't mean that you don't need further testing. It's just that it's not something that I can or should be doing for you. We need to get you in with the right specialist for further testing. And so I think sometimes people see that as they're not being believed, but more importantly, yeah, you need to listen to your patients. And again, getting back to that humility, every good doctor should have a little like angel, devil, whatever on their shoulder saying, well, what if you're wrong?
And am I more likely to be wrong if this patient is black versus white, like because I have biases or whatever they are? I think about it in the context of entrepreneurs where founders of companies, there are plenty of biases that we're all aware of. And so to the extent that I know that I may have a bias, I just, even if it's a bias that is societally present that I don't think I have, like I don't want to think that I treat a female founder differently from a male founder. But I might, and I might be unaware of it. And so just trying to pay a little extra attention in the situations where, man, and I'll notice this in my own life. I don't know if streaks come up in doctoring, but where I'm like, I've seen 3 founders who had almost exactly the same background in a row, and they were all terrible. And then you're kind of tempted to overgeneralize from that and think, or they were all great, whatever. And you're tempted to overgeneralize from that. And so the second I become aware of like, oh, I'm seeing a pattern, it's like, that's 3 data points. That is not a pattern. And I'm curious if you see streaks. My guess is there are streaks because like sometimes you actually have things going around in the community. It's like norovirus, whatever that even is. But what's the role of streaks?
Yeah. So yeah, there's definitely it's called recall or recency bias, and that means if you've seen seven people with norovirus, you're way less likely to think that the 8th one has appendicitis, and that's when you can mess up because they'll mask and they'll trick you.
Or they have both.
Totally. Yeah. And so there's absolutely recency bias, and there are weird streaks in medicine. Again, getting back to the superstition, like I can go years without seeing there's this rare condition called transient global amnesia where people just lose about like 6 to 12 hours of their short-term memory. Like it's just wiped, it's gone. And it's we don't think it's dangerous. It's not a sign of a stroke. It's just a thing. I can go a couple years without seeing a single case, and then I'll have 2 in the same shift, or one a day for 3 days in a row. And it's like, what is going on in the universe? Like, are we in a simulation?
It seems like probability plays a huge role in life as a doctor, understanding statistics of like, you talked about type 1 and type 2 thinking. I would think about type 1 and type 2 errors of like the false positive versus the false negative. And to what extent do you find yourself thinking about probabilities?
I listened to a podcast yesterday with a physician who said, we're just making bets all day. And that could not be more accurate.
Yeah.
And they're confident bets. They're bets based on our medical training and our experience and, all of this. But we're just making bets that this is a migraine, not a subarachnoid hemorrhage. This is a ankle sprain, not a fracture, whatever it is. Probability fundamentally controls a lot of what we think about. We have 2 two thresholds we think about in medicine. One is called the testing threshold, and the other is called the treatment threshold. And you have to get above the testing threshold for us to decide, yeah, I want to do a test and see if Roy has pneumonia. And then once you get that chest x-ray for pneumonia, does the x-ray look enough like pneumonia for me to then initiate treatment for pneumonia? Versus you might come in with classic flu-like symptoms and you have a cough as one of your many symptoms, body aches and everything else. Well, you probably haven't met even the testing threshold for me to do a chest x-ray on you, because it's so much more likely from a probability perspective that you have the flu.
It's a really hard awareness from the patient side that, if you present with things where the probability calculations suggest something different than what is in fact right for you, you might just get unlucky.
Yeah.
And but I think that's the reality of being treated in the system. All right. Well, the very astute observer may in fact notice that since the previous words of our conversation, we have now had a costume change, and I've had a location change too. I'm now in Wisconsin. And the reason for that is there was so much material that even going for hours on end to edit down to the finished product that friends at home will see, we had a lot to get through. So Graham, can we just pick back up where we started? We were talking about clinical work.
Yeah.
And what we're talking about is the team-based aspect of clinical work. When people think about doctors, I don't think that they often think about it as a team sport. They think about the individual doctor who is that heroic figure who comes in the room. Now that's it. I think TV has probably changed a lot of that.
Yeah, I agree.
Grey's Anatomy and ER, all that stuff feels like now everybody at least understands there's an ensemble. But even there, I often feel like it's only the doctors who really get the attention. Like there's not a whole lot of heroic nurses in Grey's Anatomy.
No, yeah. Grey's Anatomy makes it seem like there are only doctors. Like
right.
Almost everything is done by a doctor, which couldn't be more opposite, actually.
So are there moments where you watch Grey's Anatomy and you just think, that doctor would never do that?
Yeah, I can't even watch Grey's Anatomy. It's so fake.
Is there a big eye roll about that? Because I'll say, just on a quick moment of representation, of an occupation in media, I stopped watching Silicon Valley, the TV show, because it was less absurd than my real life. Like there were zero moments where I was like, that's just unrealistic. And I was like, wow, they dialed that one down for television. I mean, maybe exaggerating a bit. There must have been some moments, but mostly it was not that. Whereas you're saying for medical dramas, it may be the reverse.
There's not a type of physician that is more about medicine being a team sport than an emergency physician. I think we are extremely humble and aware that there is little I can do without the help of a social worker, a nurse, a care coordinator, a charge nurse, a housekeeper, a medical consultant. Roy, I've literally had emergencies. I've responded on the streets. Somebody got hit by a car, and I realized how little I'm able to do. I held his neck. I, held him in C-spine alignment. And I tried to talk to him and assess his level of consciousness. But, I don't have an IV. I don't even have a backboard to carry him into the ambulance. So it was very clear. Yeah, I got a lot of stuff in my brain, but that only gets you so far.
Well, one of the things that, as we were talking earlier, really struck me is that you described the patient as part of the team too.
Sure.
So maybe fully accept importance of team, wide variety of roles. The typical patient may not even understand. Like even I've been through my share of medical stuff. You named some roles there. I was like, what is that? So maybe just let's start with lay out, what does the roster look like on this medical team?
Yeah, sure. So in the emergency department, there's going to be at least one emergency physician, and then there's a charge nurse. Now, the charge nurse is like the head nurse. This person is probably not seeing their own patients, but they are the air traffic controller of the entire ER. So if I need something done that I need the air traffic controller to help me with, like I need to move a patient to another room, or I need to let them know, hey, the patient in room 5 is starting to decompensate. I think they're going to need the ICU. Or
what is decompensating?
Their medical condition is starting to dramatically worsen.
So the patient is starting to worsen. They're starting to decompensate.
Yeah. So the charge nurse can help me with anything I need. I need, hey, can you help me get in touch with the CT scan tech? Hey, can you help me get a catheter? Hey, can you help me find somebody to do an EKG on room 7? So they're kind of the air traffic controller. They like the charge nurse is critical to the ER functioning at all. There's the triage nurse. So the triage nurse typically is not going to have their own patients. They are only responsible for doing all the intakes of patients and kind of having an overview of what's going on in the waiting room.
You go into the emergency room. This is where, you encounter the nurse. That nurse is not actually in charge of you yet. They're just in charge of figuring out what to do with you for others.
And how to assign your level of severity and to some degree, how many resources they think you'll probably need.
Call everybody on earth on in this one now? Or is this one where it's like, yeah, we're going to tell you that we'll be with you soon. But the reality is 2 or 3 hours from now, we'll patch up your splinter.
Or they may assign you to a lower acuity part of the ER that says, hey, based on my experience, I think this person's probably just going to need an x-ray and then they could probably go home. And so we can move through those patients faster. So that's just kind of some of the structure. There, of course, are ED managers and directors that are running kind of the administrative work of the emergency department. And then you have your actual, staff nurse who is assigned to a certain number of patients and is carrying out all the orders I place as the physician. So they've got a list of, maybe I want the person to have a visual acuity test to see what their vision looks like. Maybe I need them to get an EKG. I need them to get an IV placed. I need them to get medicines. I need them to get hey, give them some crackers and see if they vomit.
The nurse does a surprisingly large amount of stuff.
An ER nurse is an angel sent from heaven. I don't know how they do it all.
I've seen that in practice. You're describing it. Many of those nurses, of course, have decades, literally, of experience. Why do we need doctors?
That's a good question. I'm not really sure. The doctor is trying to come up with the diagnosis and interpreting the tests. A good ER nurse can often do much of that, 50, 60% of that. Often more. But even some of even like nurses that I would trust my life with and trust my family's life with, there are just things that is not taught in nursing school that is summarily taught to everybody in medical school. And there's a little nuance of how the body works versus, the responsibilities of nursing. And likewise, there are skill sets that nurses are taught that doctors have no clue about.
Right. That makes sense.
So those are the main kind of, I would say, directly patient-facing cast of characters. And then the other people that I will rely on every single shift are, certainly I have to call out, our social workers. Many things that I'll see in the ER have to do with social challenges.
Yeah, help us imagine that, because that may be, I don't know about unique to the ER, but when I go in to see my specialist who does my annual skin exam or something like that, there is no social worker involved. So what is the social worker doing in that context?
Oh boy, what aren't they doing? Shout out to social workers are, if the ER nurses are angels, social workers are super angels. Social workers are navigating, trying to get somebody housing who maybe doesn't have access to housing. They're trying to get...
Meaning when the medical condition reveals a social or economic problem that the patient and their support system are facing, the social worker is available to try to help them with that.
Absolutely. So that could be housing, that could be access to addiction treatment resources or rehab facilities. That could be coordinating the family in 3 states who are calling, and we're trying to get the patient a caregiver so they don't have to stay in the hospital, but the family can't afford a caregiver. And could we get the patient emergency Medicaid to cover some of this? That could be the patient's uninsured, but they have a blood clot in their leg, and we need to call 7 Walgreens to see who can fill this prescription. End of life issues, you name it. Somebody might show up to the ER for, but is not truly a medical problem. Or, maybe it's partly medical and partly social. I mean, we see people who are kind of hoarders who, EMS knows them well and their apartment is really unlivable. EMS comes in and says, we can't send this person back to this living condition. That's not acceptable. Well, the social worker is going to help me try to find a place to put that person in once their medical care is done.
I got to say, this makes me feel really good about the nature of our health system. I mean, we hear complaints all the time about the nature of our health system, but the idea that you could go to the doctor and ostensibly be there for a physical condition and receive support for a whole range of context, social, familial, economic, et cetera, governmental, that sounds really powerful. And then the patient's role in the team.
Yeah, they're the active participant in their care.
Okay, so they're not the football. They are, meaning they're not the one getting thrown around by everybody else. They're not just the object of the team's attention.
I think, unfortunately, they often feel that they're thrown around. I mean, many things are, if you're coming in with a heart attack, I mean, literally the first thing we say to people is like, hey, a lot of things are going to happen really quickly to you. I'm the doctor, this is your nurse, but you're having a heart attack. So you're going to meet a lot of people really quickly, and we're going to take really good care of you. But yeah, I think often, especially with time sensitive stuff, there is so much that needs to happen in a short period of time that the patient probably does feel like they're the football.
But they can play an active role. So they're providing information to the team. They're an advocate. Let's break for a hot second on not advice for doctors and give some not advice for patients. What if you are going to be a patient to a doctor and you want to be a good patient, a patient who gets the highest quality care imaginable for the least amount of strain on the medical system as rapidly as possible? Let's just assume that's your goal. How can you be a good patient? What's a good patient look like as a member of the team?
The more specific the information you can provide to me and have that information stay the same the entire visit, the better. So, Roy, if you can tell me, yeah, this started 3 days ago, it came on gradually, but today I've been taking Motrin and Tylenol and nothing is helping. And usually when I have this pain in my side, it does help. The more specific information you can provide to me and the nurse, absolutely the better. It is way more challenging when a patient says, I'm not really sure. Have I tried anything? No, I haven't tried anything. Have I had this before? What I'm ultimately trying to do when I'm asking questions is, as quickly and as safely as possible, narrow down the list of things that could be wrong with you. And so the more specific you can give me an answer, the more quickly I can cut things off the list, because I can say, well, okay, this disease only presents suddenly. It never presents slowly. And so it can't be that disease. Well, that's one less thing to worry about.
Yeah.
And, slowly narrowing it down. So the more specific you can give your symptoms and the better you can communicate them, certainly that helps me massively take better care of you.
Patients using technology. I mean, we were talking about that before. If I was feeling some symptoms now, I might voice record them into an AI model or like into my Google recorder for later usage and be like, translate this into doctor.
Yeah.
So that, because you use words like acuity that are words that are, they're not like ultra unusual words, but they're maybe more common in a medical context than others. And I've noticed when the doctors talk to each other, they have like a very efficient, precise shorthand for all of this. And my assumption is patients could get better. It may not be their responsibility, but the more they know the language doctors use and can use that language, the less risk there is of loss in translation. And can technology help with that? I mean, I'm just kind of thinking out loud about how does a patient get better at that beyond just summoning their memory for specificity?
Yeah, I think that's a good point. I do like the idea. I think I could see large language models being very good at translating patient speak to doctor speak. So, one of the most common things is patients saying they had a fever and their temperature was 99. Doctors have a cutoff. There is a threshold. You do not have a fever if your temperature is not 100.4 or greater or 38 degrees Celsius or greater. I do not care who you are. That is the cutoff. We have decided it. And so you can absolutely have an elevated oral temperature of 99. That is elevated.
There may be a term of art in the medical profession, whereas we just use it colloquially. Like, a fever to me is like my forehead feels hot.
The other one that's very common is we will describe things as traumatic injuries, meaning you had physical trauma to your body. So we will call things atraumatic or a non-traumatic headache or a non-traumatic back pain. And that means, you didn't fall down, you didn't, bump something. Patients will sometimes get upset that, this is traumatic. And I was like, try to explain, look, this is helping me, again, narrow down the list of things that could be causing your back pain. And it has nothing to do that you're in pain or upset or anything like that.
That makes a world of sense. Let me now ask about composition of the team. I'm going to use a word that people don't use that much these days, but that we should use, and especially two white guys talking to each other, diversity.
Yeah.
It strikes me that there are many forms of diversity that it would be possible to have across a team. You talked about diversity of role. We alluded to age and experience. There's obviously demographics and, gender, et cetera. Socioeconomic class. How do you think about the composition of the team and what needs to be the same and what's good to have just in terms of the excellence of providing care? Let's set aside societal obligations and all that stuff, but just excellence of care. What forms of diversity underpin excellence in care?
I think the closer your hospital or your care team can get to the same types of diversity as your community, the better.
Oh, fascinating.
So, if it can mirror it, I mean, no one can ever mirror it perfectly. Some days, like it's all male doctors in the ER. Some days it's all female. Some days there's no Vietnamese speaking nurses. Sometimes there's two. There is a tremendous amount of variability, but it is extremely powerful. And in fact, there's data that when the doctor has qualities in common with the patient often has a slightly better outcome. That's probably some sense that the doctor can see themselves or their family member in the patient. And it's probably easier for me to be a gay male ER doctor and see a gay patient because we can talk lingo.
And they may feel more comfortable volunteering things to you. Like I've noticed, I feel more and less comfortable based on the affect of the doctor. I'm sure I have all kinds of subconscious biases around, well, if the person's younger than me, I might treat them differently than if they're older than I am. I don't know.
I was just talking with a colleague who is my same age, and like us now being in our mid 40s definitely changes the way we interact with our patients because there are more patients that are our age now too.
And let's talk about the role of geography in this. I mean, you are based in the San Francisco Bay Area. It is a geography that, not unlike others, but it has tremendous economic diversity from one neighborhood and one medical facility to another. It has different neighborhoods. It has, obviously it has a particular history of openness with respect to, LGBT, community embrace and all that kind of stuff. How is it different from place to place and maybe in the areas where you work in particular?
Yeah, I trained in New York City, again, major city, but there's definitely a different flavor. New York is more in your face, certainly.
People say to me as a New Yorker, of course, I'm a New Yorker too. When they say to me, "You're very East Coast in California," I think they mean asshole. But it is a very different kind of a culture.
Yeah, but in some ways, I actually really appreciate the New York culture because New Yorkers will just be very direct. I mean, you get what you get, and you can tell immediately somebody upset is upset. Versus, I'm from the Midwest originally. There's a Midwestern passive aggressiveness there, but New Yorkers,
Minnesota nice.
Yeah, totally. New Yorkers will be very direct, and you know exactly what you're getting. But there's also an expectation that you give that back to some degree, even as their medical professional, and so that's acceptable. That's acceptable versus some of the ways that patients and staff and doctors engage in New York. If you took that exact same conversation and language and emotion to San Francisco, it'd be wildly inappropriate.
That makes tons of sense. And so my guess is when doctors move from one geography to another, they're learning new norms, new ways of speaking, that kind of thing.
I mean, and even just practices of, how diseases are managed or how we manage a particular condition. Do we hold somebody in the ER overnight or do we send them out at 2 a.m? Like in New York, 2 a.m. is fine. There's people everywhere in Manhattan at 2 a.m. versus here in San Francisco, the city's pretty quiet by 10 p.m. And so we're way more likely to kind of hold people till the morning.
The other thing that it makes me think of is that in different places, I think my experience is that the community sees the role of doctors differently. So for example, I think about in Boston, everybody talking about somebody being every doctor, it seems like is also a professor at Harvard Medical School, in Boston, but there's great esteem. It's one of the sectors for which that place is so known. And of course, there's great respect for many Bay Area medical institutions. And at the same time, I think there's a bit less reverence for medical professionals in the Bay Area. It's sort of like, I don't know, did you start a startup? I mean, you did. So you get special 2-category treatment. But I do think there's less reverence in the Bay Area, maybe for doctors.
Yeah, I totally agree. I think, it's like a running joke. Often make small talk when I'm like suturing or something. And, 95% of my patients, oh, you're in tech. And then I make a stupid joke about, oh, in this city, so Absolutely. I think
Right. All the doctors in LA are also screenwriters on the side.
exactly. Yeah.
Um,
Yeah.
it makes sense. Before we talk about the other aspects of being doctor as an occupation, anything as you think about the clinical side of your work, meaning the treating patient side of your work, that you want to make sure that we hit?
I mean, I won't be able to name all the roles, but again, could not do my job also without pharmacists and ED pharmacists
Oh, yeah.
and transporters and radiology techs.
Sorry, a transporter is like the guy driving the ambulance.
Moves the patient from maybe the ER to the CT scanner. Yeah.
Oh, somebody who wheels your bed around the hospital.
There are so many roles that everybody says doctors and everybody says nurses, but there are so many critical roles that I could not deliver my care without. So
Makes sense. Well, I really appreciate hearing that and the expanded point of view. Okay. So, one area of medical occupation that folks don't tend to think about very much is academic research.
sure.
And, we've done already here a lengthy conversation with a scientist about scientific research generally as an occupation. So, I think what I'm interested now in is the special nature of that within being a physician. Does every physician do research? Is it common or uncommon? How do you think about whether to do research at all as a physician?
I would say most physicians have done some sort of research, whether it's something during college to see if they want to be a scientist or it's to help pad their resume to get into med school. And then once you get to med school, your research options are way broader. There is clinical research, which is different than bench research. There's qualitative and quantitative research. There's research that's really focused on like clinical operations and care delivery. And so the research expands drastically from maybe what you're probably exposed to, say, in undergrad as well.
Yeah, that makes sense. So there's a whole wide range. You can do it. For people who want to do it, why do people choose to do it? Let's start with that.
I think every medical school probably encourages their physicians to do research because the med schools are, of course, research institutions. They want to encourage the best and brightest minds to contribute to the literature, the knowledge and the understanding of science and the body and humanity. So I think most med students are encouraged to do it. I think a lot of researchers do it because they're trying to honestly take better care of their patients.
They think research makes them better clinicians.
Well, I think it makes them try to understand the world better and understand their patients better. And hopefully that then unlocks better care. So if you see you see all these people with migraines and they tend to get better when you give this medicine. Well, that's weird. Why? That's not a migraine medicine. Why did they get better? So now you get this question in your head. What is going on here? The world is so complex that every shift, I'm sure there's a research question that I could try to tackle to try to be a better doctor and then deliver better care to my patients.
That makes tons of sense to me. And now let's just talk a bit about the logistics. Isn't quite the right question. So if somebody has an MD and did some clinical work and then goes to be a researcher, they're kind of fundamentally, I think of them as they're like a professor in a different discipline. They may be doing studies of organization. They may be doing, as you said, clinical studies with patients. They may be doing bench research. It's a little harder for me to imagine what it looks like for somebody. And I know many physicians do this, where they're both doing the doctoring clinically and they're doing the research. And so how does that work?
Those people typically are going to be usually are called clinical researchers. And so that's not somebody that's pipetting stuff all day.
Very few people do the biathlon of I go see patients and then I leave and I look under a microscope at something that has nothing to do with my patient course.
Yes. Researchers will maintain a small clinical practice. So maybe, at Stanford, there's a ton of professors who maybe 4 weeks a year, they are on service and they're running the oncology service.
I want to make sure they don't lose their thing. They're riding the bicycle to stay fresh.
Yeah. The clinical researchers are typically people who are going to be working a certain number of hours and they've gotten some buy down on their clinical time. That's either through their own institution, through the NIH.
Buy down meaning they're getting paid by the institution to do that work so that they're not foregoing their income, let's say.
Yeah, they're trading. They've got a grant, say, coming in so they can tell the ER, hey, I'm going to work 6 less shifts a month because I'm going to get my income from somewhere else. And so you're going to need to find a warm body for 6 other shifts. And in that time, they are then, funded to do some research that a grant has approved. And it's obviously going to be in their specialty. So we've got like 10 or 20 emergency medicine physicians who do emergency medicine research and publish a ton of papers on emergency medicine patients. So how can we better diagnose disease? How can we find the right patients to send home? Which patients should we put on blood thinners? All of those type questions. You have that for every field. The 2 biggest ones are going to be oncology and cardiology, certainly by far, because there's the most trials in cardiology and there's the most new medications and certainly funding for cancer research. And so those are cardiology and oncology tend to be the largest, and people that go into those fields are way more likely to be clinical researchers or to even go into industry, right? To go work for a drug company or a device company and stop. Usually those people are not practicing, or they, again, are practicing a little bit, but they're running, say, a research trial on a new chemotherapeutic agent or something like that.
If somebody were to come to you and say at the outset of their career, I'm unsure if I want to do research. I haven't picked a discipline yet, a specialty. We talked a lot about specialty choice. We didn't talk about it in the context of, well, by the way, that sounds like some specialties are more and less team oriented. Some of them
Sure.
are more and less research oriented.
Yeah.
How does the question of whether to do research play into the choice of what discipline to work on?
Oh, that's a good question. I mean, there are MD, PhD programs, and those are funded by the Howard Hughes Institute. So essentially, those people get a free medical education. So they are funded for all 8+ years of their training. So they'll go do a couple years of med school. And in those years, they're like finding the right research partner that they want to work with. Then they'll go work in a lab for 4+ years. And then they'll get their PhD. And then they'll go back and do their last 2 years of med school. And then they'll go off and do a residency or go work for industry or, do whatever they want.
I think they're doing it to save money. And the Howard Hughes Institute, presumably private philanthropic foundation, that just wants to see more of that research being done in the world.
That's right.
Fascinating. If you're doing research as a doctor, do you need a PhD? What role does obviously a PhD allows you to spend time and effort studying research techniques and publishing, but tell me about the relationship between the choice to do a PhD and the choice to do research, because I vaguely understand that there are some physicians who do research who don't have PhDs.
Yeah, I mean, I've done research myself and I'm published and I don't have a PhD. Certainly PhDs are going to lean, I think, heavier toward more rigorous research studies, larger, more complex trials, probably skew a little bit more toward basic science research. So more pipetting, less clinical trials, but there are absolutely tons of great PhD researchers that are doing clinical research as well. It's another specialization to hone your skills in being good at a particular craft. The other thing that medical students are really good at is they're really good intern researchers. So at the med schools, all the professors want a med student to help them with their project because they're kind of cheap labor. And so it's a trade-off, right? The med students gets exposed to, a PI.
Head of a lab, the principal investigator.
So they get exposed to a PI and they get to, often get published in a paper eventually. And the PI gets some cheap labor and they both start to get to understand, hey, is research something I want to do as part of my career?
Sort of one of the rotations that an aspiring doctor might do as part of their medical training.
Yeah, in fact, I mean, Stanford, where I went for med school, is so encouraging of research. It is like almost free or maybe even cheaper to spend an extra year at Stanford Medical School doing research because they'll fund you. Your final year of med school is like literally 10% of the price of a full year normally. And so you end up, and if you do some TAing and teach some classes at the same time, you can you're really highly encouraged and motivated to do research because they want to encourage people to try it out.
Yeah. So, and by the way, I definitely get how, as you described, research, of course, those are institutions that thrive on research. That's in a way their business, their core. In a way, everything they do is intended to produce new insights about new knowledge about what works medically. And I understood what you were saying about how being a researcher, a good researcher could make you a better physician, does the arrow flow the other way too? Like, is there a reason to think that if you want to study something biological, going to medical school or having served as a physician makes you better at the research?
It's a great question. I'm sure researchers would say it does. And I think if nothing else, it would motivate you to really work harder, drive at really solving this problem because you see the suffering of your patients every day.
Okay. The last piece that we talked about was the administrative piece of the medical occupation. When we think of lawyers or accountants, we think of people shuffling papers. When we think of doctors, we think of them holding a clipboard maybe for the charts. We don't tend to think about doctors as administratively very active. How do you think about the role of the administrative side of the job? What is it first?
It is a set of policies, rules, regulations that need to be followed because of institutions, governments, organizations who've said they need to be followed. And so that could be anything from a required committee. By law, every hospital has to have a certain number of committees that review information, that look at unexpected deaths in the hospital for patient safety and licensing reasons. There is quality work where, Medicare will pay the hospital more money or docket money if it has good or bad quality. And so there needs to be a quality review. And so that's all kind of administrative work. And then there's just all the other kind of medical, legal stuff that happens. Doctors need to get credentialed and prove they are who they say they are. Well, like you have to show them everything from your college diploma on and, every place you've worked and disclose all this information. So there's a lot of bureaucracy. And I don't use that in a particularly negative way, but it's just like there's a lot of stuff in the name of patient safety and reacting to problems that medicine has had in the past, that we've established all these rules, and the rules have to get enforced and have to get reported, essentially.
Yeah, I mean, I remember reading, what is the Atul Gawande book called? The
Checklist Manifesto. Yeah, sure.
That spoke to some of the advantages, of course, of some of those procedures. And we all know, we're not going to enter into a whole conversation about like which kind of bureaucratic procedures are good and bad. Although I'm happy to hear if there's particular resonance in medicine. What's the most time-consuming part?
That's a good question. For me personally, sometimes there are 10 or 12-page forms that even me, the ER doctor, who has never met this person before, does not have a prolonged relationship with this person, I'm asked to fill out about their dental habits and can they change into their own clothes themselves? And again, shout out to nurses and social workers that help me with handling all that paperwork. I think the other challenge is much of the paperwork, a legislator or a regulator has decided the doctor is responsible for. So it cannot be signed off by a nurse. It cannot be signed off by...
That's why we need doctors, paperwork.
Yeah. It cannot be signed off by the caregiver that knows this, that's worked with this patient for 7 years. It has to be the physician, and I have to sign off on it.
Sort of stuff that you're not equipped to do, but required to do by law or for some other reason, it sounds like. So that's the most time-consuming part. What do you think is the most pointless?
Oh, how much time do we have, Roy?
We'll talk more about the system in a minute, but in terms of the experience of doing the administrative side, why do we do this?
There is a lot of pointless documentation that is required to be done for, regulatory bean counters or for other people so that the patient can get to the next step of their care. And even though it is a waste of my time and provides no value to the patient, no value to anybody, it's kind of what we call CYA or kind of cover your ass stuff. And that happens all the time. And then you get to decide, hey, am I going to fight this as the doctor and say, this is really stupid and what a waste of my time and effort? Or do I just put my head down and do it because my goal is ultimately to help the patient get on the next step of their journey?
I love that, knowing that, not the fact that you are having to do that. In the business world, there is an analogy for the doctor being forced to sign the thing, but it is the requirement by law that certain documents have to be approved by the CEO. That basically you want the person not to be able to say, I delegated this to somebody else. So I understand in principle, the reason for that is the setting set in the right place. I don't know. How does that kind of administrative work differ? Well, actually, let me just ask, what percentage of your day would you say you spend doing something administrative as opposed to doctoring?
Yeah, I mean, it depends on if you count note writing as administrative. I mean, if the note needed to only contain truly the pertinent information to making sure the patient gets the best care possible, the note could be a third, a quarter of the length of the note. So I think generally speaking, the ratio of patient care to administrative work is very good in emergency medicine compared to other
Mm.
specialties, but it's definitely crept up over the past 2 decades for sure. I mean, the other piece, Roy, is that no paperwork is ever taken away from healthcare. No one ever removes a regulation or says, hey, let's get rid of this form or let's get rid of this field that you have to click the checkbox in. It is only added, and it is literally, I mean, if you want a rule for healthcare, nothing is ever taken away from regulatory.
We haven't really talked that much about how being a doctor differs by setting. I don't know even what the settings are. You're in a big hospital system. You have your own private clinic. You have a shared clinic with other doctors. How does this aspect of the work differ depending on the setting? And what are some of the major settings?
Yeah, Roy, the one of the things you learn in medicine, and there's pros and cons to everything. So, if you work in a large health system like I do, an integrated health system, we all use the same electronic health record. That's amazing. I can see all the data from everybody else. I can see everybody's labs. I can see
A digital system that stores like Epic or something,
Yeah.
like they don't have to go call the person and be like, can you please fax their dental record?
Yeah. And, so that part is amazing. But the EHR that we use is not customized to be personally optimized for me, the ER doctor. It's optimized to work well for everybody. Versus if I worked in a small private allergy immunology practice, I could probably decide to buy the EHR that's perfect just for allergists and immunologists, but I wouldn't have access to all the information. I'd probably have to get faxes all the time from other users and stuff like that. I think that's the particular difference. And then I guess the settings are, generally inpatient, meaning the ER, the hospital, the ICU, and then the OR. So that's going to be like anesthesia and surgeons. Outpatient, where most people get most of their care.
Well, hold on. So this is one of these phrases that I never quite understood. Outpatient means you don't sleep at the hospital?
Yeah, it is a good question. I don't actually know where they come from, but yeah, inpatient is you're admitted to the hospital, you're spending the night there. Outpatient, or sometimes it's called ambulatory care, meaning you're walking in and walking out.
Yeah.
So an ambulatory clinic would be, hey, you check in for an appointment and it's all scheduled care typically.
Not to be confused with the ambulance that typically has nothing to do with walking. As you figure out how to be a successful doctor, what role does the choice of institution and or setting play in how your experience evolves as a physician?
Yeah, I think the institution you choose is critically important. As we're doing with Off-Call Roy, the work that a physician does and the hours that we spend at a place are just as important as the pay. And that's going to be some mixture of like the structure of the organization, the relationships that you have with the other people you work with, the culture, what the goals are of the people. Is everybody there just to get paid and they, could care less about if something bad happens to a patient? Or is everybody like, hey, we are all in this to surround the patient and help them? And you can have two places that have diametrically opposed ideas about the right way to do things are. And so it's a little bit of I think, a personality fit and a culture fit. And that'll absolutely, honestly, determine how you practice medicine.
I have seen or heard about cases where the culture of care delivery is dramatically different. Like I had a friend who went to the Mayo Clinic for something, and I vaguely understood that the Mayo Clinic was very famous for the nature of how it provides its care, maybe for other things too. And I never quite understood why. And so my friend went there and I said to her, I was like, how was it different from other things? And what I remember the conversation, she said, well, they really operate like a team. Like the different specialists work together. It's like, sort of sounds like, isn't that what everybody kind of does? And then I thought about my own experience, and I often felt when somebody was referring me to the next doctor, like it was a little bit of being thrown over the wall. It's kind of like, listen, I can't help you with that. Maybe this other person can, but my responsibility for you ends as soon as I conclude my discipline can't help you. You might get an appointment a little sooner because you got the call from the other doctor, but mostly it felt like at that point you were on your own and there was nobody other than you who was actually taking responsibility for your care. Is that the kind of cultural difference you're talking about? And by the way, is there something special at the Mayo Clinic that the world deserves to understand?
I've never been to the Mayo Clinic. I do hear from the patient experience, it feels very coordinated, like extremely coordinated, and regimented, and in a really good way. And yeah, I think it does get back to kind of ownership of the patient. If I had any criticism of American healthcare in the past, whatever, 40, 50 years, it's really the decline and maybe even collapse of primary care. Ultimately, in any other countries, your primary care doctor is owning everything. They are coordinating everything. They are translating. Oh, you went to the cardiologist and you didn't really know what the cardiologist said? Hey, come to see your primary care doctor and they will explain exactly what cardiology meant about why to start these medicines or do this test or whatever. And because we have systematically not encouraged primary care, both financially and both like from a medical culture, not thinking that primary care is worthy, that has triggered patients to suffer in that same way of not owning.
Yeah, I will say I'll just take a second for a shout to Dr. Swan, our family's primary care physician, who has taken it on herself to be that coordinator. My sense is she has to do it. I mean, she's often helping me figure out why did that prescription get delayed and that kind of thing. And my sense is she has to do it despite the system. And so that's its own setting. There's another aspect of this administrative side, which is administrative leadership. Like there are doctors and then somebody is eventually the chief medical officer of the hospital. What are the forms of leadership that are available? And do most doctors want to do that? Or is that like, how is that seen in terms of a doctor's, professional experience?
Yeah, I think it's physician and maybe specialty dependent. I think there are a couple routes. One is certainly through the clinical department leadership role. So somebody's got to keep the ER doctor cats herded together. And so somebody's going to be the chief to represent the ER in working with other departments, coming up with agreements with other departments. Hey, when a patient comes in with this type of condition, who's going to manage it, everybody? Is it going to be the hospitalists or the surgeons, or who's going to, agreements like that? And, things come up in hospitals and problems happen. And so someone's going to have to investigate those problems and respond to them. And then there are more functional roles where if you're particularly interested, you can become a leader in that as well. So you could be the head of the quality department for the hospital. And so you are looking at a functional area of, hey, what are our infection rates of our ORs? What are our rates of falls in the ER? What are our rates of smoking cessation in the clinic? So all sorts of metrics looking at quality response as well. Those are probably the two main tracks.
You mentioned that the time spent has been ticking up gradually over time, and it does make sense that an ER doctor who has to deal with more urgent needs would have less of that than other specialties. I guess I would have thought that technology would bring the time down and maybe bureaucratic requirements would go up, but they might net out with each other. And we talked about it going up in general. Tell me about the effect technology has had on the administration.
It used to be, Roy, and I think this is honestly even before I was in med school, but I get the sense that there was just a little bit more trust that if a doctor said somebody needed something, they needed something. Nowadays, I have to document and prove that they need that thing way more often.
Because of money? I mean, is that?
I would imagine so. I mean, I'm sure it's probably a mixture of money and regulatory reasons and, reactionary laws and stuff like that. But, it used to be that like, if I document the labs are normal, then the labs are normal. But nowadays, you might have to list out the labs and show that they're normal. So technology has also made it possible to require all that documentation. It used to be that, doctors had one page and in the ER, you just checked a bunch of check boxes and there wasn't room to type out.
Right. Now, if you want to add question 72B, the marginal cost of adding the question is 0.
Correct. You can do a minute by minute assessment and document it all. And now that's become more expected because you can.
Is stuff recorded? Like there's a case to be made that like there'd just be video cameras everywhere and then you wouldn't have to write anything down. But my sense is that's not how it works in a medical setting. And as a patient, I would not love that.
Yeah, no, there's not recording, certainly if we use an ambient scribe or an AI scribe technology.
It means I'm audio recording this conversation just so we can write down a transcript.
Yeah, and then it's typically, deleted or deleted soon after that. But yeah, no, there's no, video recording, certainly for a myriad of reasons, including patient privacy.
What you're saying is that technology has enabled the collection of more information, but that may also just be annoying for everybody involved or too much and put additional obligations on the doctor.
Yeah, it makes it easier to fill out the form because, great. Now the form can be pre-populated with the patient's name, but now everybody expects the form always. And now it's not one form. Well, why don't we just have them do 2 extra forms? Because it's, like you said, that the opportunity cost is just like it's 2 extra clicks for the doctor. Well, if everybody thinks that we need 2 more forms, now the doctor has 12 more forms per patient.
Tragedy of the commons. That makes sense. Okay. So now I want to turn to the topic of career progression for a doctor, because we talked about sort of the training. We talked about the snapshot of being a doctor, but sort of looking forward on how a person's career evolves. Let's start with this, which is, how do you get better at the job over time?
I'll throw it back to you, Roy. Do you get better at the job over time?
Okay, let's start with that one. Even better. Do you get better at the job over time?
It is really interesting, Roy. We just talked about leadership. Unless you are progressing in your organization as a leader, most physicians may just do the same thing for 30 more years. You finish residency at 35.
You may not have interest in continuous improvement.
I think every doctor wants to.
If you ask somebody if they're interested, of course, everybody says yes. Everybody thinks.
Yeah, no. Better. Well, I just mean, they may do the same thing for the next 30 years, meaning they 9 to 5, Monday through Friday, they see patients all day long. And their role, the work that they do doesn't change versus, I get the sense in tech or in other organizations, you start out as an intern and then you are a programmer and then maybe you get promoted to architect.
Yeah, it's interesting. There's this attitude. I used to work at a management consulting firm where the explicit policy was up or out. You had to keep progressing or else you're going to leave. There is no up or out, I don't think, for doctors. It's like the cardiologist doesn't get up or out. If they're providing good cardiology, they keep doing the heart surgery or whatever.
Yeah, they're going to keep reading the echocardiograms for the next 30 years. Now, are there advances in medicine that we all should be adopting? Of course. But generally speaking, I do other things, but many ER doctors, they're just going to go work shifts in ER for the next 30 years.
And by the way, like, no judgment on that. That seems like, it's like the same way that the person who is the tradesperson who makes a building, may just keep building buildings,
It's fine. Yeah. Yeah.
Then under what conditions does somebody improve at the job?
I think they absolutely need the feedback to know where they can improve. We don't, some people say, you can't improve what you can't measure. And so getting a sense of how your patients are doing.
How do you get a sense of how well you're doing as a doctor?
Generally, you can compare to your colleagues to some degree. There's ways where people try to make everybody's list of patients have the same amount of disease to, compare. And
right. Because I'm sure some people say like, yeah, of course, more of your patients died. You had sicker patients than I did.
That's always the challenge, is comparing groups of people. I will get feedback from my chief of my department that shows where I am in my 30 colleagues in terms of how many CAT scans I order.
Oh, interesting. So some of it is inputs, meaning are you making different decisions than your peers?
How many opioid prescriptions am I writing per year? Am I on the higher or lower end? Now, some organizations, I think, may be more punitive. Other organizations are more like just giving the doctor access to that information, may change their practice. And I do think that actually does significantly change doctors' practice, because we all want to conform and be like each other. It is a data point. Now, a counterexample is if you have a doctor who only works night shifts, well, the only type of imaging test they have, is X-ray and CT scan. So of course they're going to do more CT. They're going to look like they're way higher. Ultrasound's not available at night at many places. Or of course they maybe see fewer patients per hour because between the hours of 3 and 5, there are fewer people that show up. And so you have to take into account for that. But, generally speaking, there are at least some things we can agree on, like generally speaking, getting more people to stop smoking is generally going to be a good thing for everybody. So there are some metrics that help us.
Metrics that have usefulness in some cases, less usefulness in others, like all metrics. You'll get some direct feedback provided by your organizational, whoever's responsible for you in the organization. I don't like the word superiors because it implies hierarchy. And I think the hierarchy can just easily flow the other way. So those are some of the data signals for getting better. Are there other signals that help you get better? I mean, obviously patients talk to you and they say, ouch.
Yeah, patients will be happier or less happy with our care.
Are there like satisfaction surveys? I'm kind of trying to think. I feel like I've sometimes been surveyed on that, but not that often.
There's net promoter scores in healthcare now.
Right. So for folks who don't know, a net promoter score is that question you've sometimes seen on a survey that's like, how likely would you be to recommend Dr. Walker to a friend if you ended up, tripping and breaking your leg? Got it. And then let's assume you then have this package of inputs that tells you ways in which you ought to get better. What are the most common mechanisms for then actually improving? Like, do people go back to school for stuff? Do they get trainings? Is there such a thing as continuing what's informal with the mentor who what are all the different ways you learn to improve?
Yeah, so there certainly is mentorship at most health systems, I would say. Yeah, we have a formal process of continuing medical education. All physicians have to get a certain number of CME, continuing medical education credits per year in order to maintain our board certification and our medical license.
Those are two different things. I've actually never quite understood that. Medical license. Yeah, just tell us what those are for a second, because I feel like those are two important hooks.
Yeah, so my medical license is provided to me by my state, and I pay the state for the privilege.
You have passed some exams and other requirements, and therefore you are legally allowed to practice
in our state. And, I mean, one of the sidebar, some physicians also feel like it's crazy that it's still state by state. I'm originally from Kansas City. So if my dad he practices in Missouri, but if he wants to practice in Kansas as well, he has to get a separate license as well and pay another state fee.
Because the body does not change from state to state or even from country to country. I mean, maybe it does to some degree, but just patterns. But the core human body, it's not like law where like I can make the case, okay, California has different laws than Kansas does. Obviously it does have some different laws as they pertain to medicine, but the core practice of medicine,
pretty similar.
We would hope,
Yeah. So that's the medical license. And then the board certification is through every medical specialty has a medical board.
Oh, I see. The cardiologists say, according to your peers, you are allowed to be a cardiologist by the peers of cardiology.
Correct. You have been, and for emergency medicine, we have to take a written exam and then an oral in-person exam because we have stuff that's like life-threatening, that's time sensitive. And so there's a full day where you get interviewed by a more senior attending and they say, hey, how would you manage this kind of scenario? And they kind of grade you on a rubric and stuff like that.
Is it bullshit?
Yeah.
Because usually those requirements are kind of bullshit.
It can be bullshit. I mean, you can
satisfy it with bullshit.
Yeah. You can, but I think generally speaking, nobody wants to be the odd man out that's using medicines that are.
Right. You're still bloodletting. What are you doing here?
Yeah, exactly. So you can take a trip to Hawaii and learn about emergency medicine. You can do online courses. You can buy a monthly magazine that'll give you, an update on managing appendicitis or, whatever it is.
There are many alternative traditions in medicine. To what extent does continuing to learn how to be, keeping our focus on MDs in the United States of America or other Western countries to the extent it applies, to what extent does learning about alternative forms of medicine, including, by the way, holistic thing, nutrition, and, I don't even know what else, social conditions. How does all that stuff factor into learning?
I think you typically need to know that it exists.
You have to seek it out.
Yeah. Oh, yeah, for sure. Lots of patients I see, especially here in San Francisco, will have cupping or,
Cupping is like, it's like suction cups.
yeah, like suction cups to kind of increase blood flow.
Just increase blood flow in quotes. If you did, that's okay.
I did. Yeah.
Yeah. Okay. Just checking. Which is to say that I think what I hear you suggesting there is in the core tradition of Western medicine, which is scientific research, now peer reviewed, maybe there isn't peer reviewed evidence for increased blood flow from suction cups.
Or maybe there is, and I don't know it.
Fair enough. Okay. We'll get to the research in a second. But okay. So you have to seek it out. Keep going.
Yeah, you have to seek it out. But I think generally being aware that it exists, that people are going to these, what I would consider alternate practitioner, you need to consider like kind of sometimes like what the side effects could be. So I've had people who have collapsed lungs from going to the acupuncturist. I had people who are taking an herbal medicine and go into liver failure. And so like I need to consider how other people are seeking, their version of medical care so that I can make sure that I'm covering all my bases for my version of medical care.
So that makes sense. And my guess is that there are also beneficial practices that people learn about, and then based on their integrity as a practicing physician, the same way as they combine different kinds of medical scans, they might also combine techniques that are not taught in the canon of a medical school in the United States.
Yeah, a Western understanding of the pathophysiology of disease, as we would call it. Any Western physician who thinks they know everything about the body is just waiting to get humbled. So are there alternative ways of looking at the body and curing disease? I don't know. I mean, I'm humbled every day by the biology of humanity,
Do the crazy things you see as an emergency room doctor vary by season of year?
Summer's going to obviously be explosive firework injuries, and there's more alcohol and more people are driving drunk. And summer tends to have more of a trauma flavor because more people have time off. Certainly kids are at camps and playing outside and fall and, break their wrist or something like that. And then winter is going to be way more infectious disease. So flu, influenza, people are indoors. Things like that as well. And then I don't know if there's a particular spring and fall flavor. Certainly here in San Francisco, we'll have maybe 3 days a year that are what is considered hot to San Franciscans, which is like in the 80s. But, San Franciscans don't have air conditioning. Almost none of us have AC. And most of our, especially older patients wear 7 to 8 layers all the time. And so in a hot third floor apartment, where grandma has 7 layers on and then it turns 80 degrees, we'll see huge waves of hypothermia, who, need to be rapidly cooled. And we, need to strip them naked and spritz air onto them. We have these big utility fans that do evaporative cooling to cool them off.
And are there things that ER doctors know about certain, like you mentioned fireworks, and I just thought, well, that's a 4th of July issue where it's like, oh God, we're going in on Christmas. It's going to be the kids who swallowed the ornaments again this year or something like that.
Yeah. I mean, there's the classic, like Thanksgiving morning, early afternoon is like, the electric turkey carver knife is a classic one. In New York, it was the Sunday morning bagel injury. And here in California, it's like the Sunday morning avocado injury because people are like slicing through a bagel and they lacerate their palm that way as well.
And does that kind of thing, these kinds of things is that the stock and trade of an ER doctor?
Yeah, those things are highly known to emergency medicine and, maybe urgent care, but nobody else because it's a time-based thing that like, oh yeah, this always happens. And, there's even like truly medical things. If in New York, whenever the ambulance, we call it the bat phone, the red phone, that means there's an ambulance coming in without a fail at 4 a.m. if it rang, those are patients that would come in with something called acute pulmonary edema. And it tends to always happen very early in the morning because fluid has reaccumulated in their body. And essentially fluid gets into their lungs and it causes them to get extremely short of breath all of a sudden. And so we literally would know, we would take bets. Hey, $10 on
pulmonary edema.
Yeah. And then I guess the other one is, croup, which is a common pediatric ailment, like a seal barking cough in little kids. That almost always comes in in the middle of the night because it tends to get worse at night. And then the other thing is that for some reason, the cold night air tends to make the symptoms better. So often by the time the kid gets to the ER, the parent is like, I swear they were breathing much worse and they looked way worse. And I said, yeah, I know this is croup. They're always better by the time we get to the ER because you've been outside. And
Fascinating. Okay. So just back on the continuing learning, the informal kinds of learning where you're not in a classroom being trained or subscribing to a magazine. We all have mentorship in different occupations. Somebody who looks out for you, takes you under their wing, gives you some advice. How does that work in medicine differently or the same as in other, how does all the informal work of learning happen in medicine?
We talk to our colleagues all the time about interesting cases, or we'll share, at a monthly conference, like, hey, this was a really interesting x-ray. We've never, you may never see this disease present again. So I wanted to tell you guys about it. Or this is a weird presentation of a patient who came in with kidney stone, whatever it is. And then, like doctors are human too. We've got like group chats, and sometimes it's stupid memes.
What do you use for group chat?
Oh, I mean, some are on iMessage, some are on WhatsApp, some Facebook groups. And, it's like a mixture of there's stupid memes and cat videos, but then there's also like.
Yeah, no, there's like serious stuff.
Yeah, there's like a PDF of an interesting new article that came out.
Oh, so this is another thing I wanted to ask. A difference in medicine compared to many other occupations is we were just talking about research, a steady stream of new findings, some of which may end up being nonsense, some of which may end up being significant. How do those new findings were scientific research, like somebody discovers the thing you used to always do actually turns out to hurt the person, the left, right? We were talking about the heart attacks don't actually happen on the left. That was an artifact of who they studied. How does new medical research circulate into the practice of actually doing medicine?
Yeah, there's a couple of ways. Sometimes it's a groundbreaking study that literally the day this study comes out, the standard of care changes.
An example of that.
So there was a study back in, I want to say 2015 or 14, looking at clot retrieval for strokes. So if you come in with a particularly bad stroke and we see that there's a clot in your artery, your middle cerebral artery, a big study came out like in February that said, hey, patients do better if we try to go in there and suck the clot out. Now, you can imagine going into somebody's brain to suck out a clot is risky as well. So we weren't sure if this was helpful or not. And so the day this came out at the, whatever neurology society, literally that day, the guidelines changed. Now everybody needs to kind of figure out, okay, how are we going to do this new standard of care? Because these patients, we took people who were paralyzed and fewer of them were paralyzed later. So sometimes it's a groundbreaking study, and the societies themselves will get a bunch of press releases ready and talk to the media and embargo them, and then the day it comes out, the New York Times has an article on it already, and then sometimes it's way more insidious and slower, and it's, hey, there's a couple small papers that look like there's evidence to support this, and then maybe at a conference or something, a person who's particularly interested in the management of migraines will start to tell their colleagues about it and say, hey, do you guys know that there's now 5 papers that suggest that using this particular treatment is better than all the other treatments for migraine? And then doctors start to talk about it more. And then slowly it makes its way into maybe a guideline from a society. And then now the guideline says, hey, here's probably the better way to manage this condition.
So the guidelines are definitely a major aspect of formalizing the recommended practice. It seems like there must be lots of stuff that's debatable at any given time. Obviously we have this whole conversation happening in the US about, people critiquing the entire medical establishment over things like vaccines. I'm not even talking about that stuff. I'm talking about sort of debate within the medical establishment.
Yeah. My biggest criticism of the guidelines is guidelines cannot and will never include all the diversity of human biology. So you could say, this medicine is better for migraines. Well, that's not going to be correct if the person has an allergy to that medicine, or the person, has another medical condition that's contraindicated with that medicine. So guidelines are a good framework to say, generally speaking, most of the time, you should or shouldn't do this with this type of scenario. But again, the expectation is the doctor is thinking of the individual patient and their individual risks. And sometimes the guideline's going to be incorrect as well.
One of the things I've noticed that doctors often do is they innovate, over the course of their career. They themselves improve upon a method.
Yeah.
And oftentimes, there's always this cliche of the doctor who starts a medical device company because they learned about, something. You are an entrepreneur in a different way. We'll make sure to get a chance to talk about off call. But what role does innovation for a physician play in the development of their career?
I mean, physicians see every day the ways, in the same way that we talked about some people wanting to better things by doing research, other people want to better things by doing innovation. So they are solving the same or a similar problem in a different way. They're trying to, instead of answering a question, they're maybe trying to come up with a new technique. I'll give you an example. My colleague, Brian Lynn, came up with a way to manage fingertip skin avulsions. I'll explain it. So, when you're chopping food and you're slicing a little too quickly and you just slice off the very tip of just a little bit of skin of your fingertip, or maybe you're using a mandolin and you're like, zoop, there goes the.
You're talking to a
the
person who cooks a lot and is very clumsy. And so you're just literally describing my nightmare.
So Roy, that's a fingertip skin avulsion. And those bleed a lot.
I don't, but I did see when my wife cut her hand with something in our house, hands seem to bleed a lot.
More correctly, they don't stop bleeding very easily. So they may not bleed a large quantity, but it's like,
it's not like slicing an artery.
It doesn't clot, correct, because you've sheared off all the capillaries. So my colleague Brian, this is obviously a very common ER complaint.
Like, we got you a shower cap for your finger.
Yeah. So my friend Brian was like, there's nothing to suture, right? The skin's gone. It's missing. You can't just suture that back on. So he figured out a way to deal with this. So you put a tourniquet on the finger and then you dip the finger in some numbing medicine that has a vasoconstrictant in it. Then you milk all the blood out of the finger because you got a tourniquet on it. You get it nice and dry. And then you put a layer of glue on top of it. And the glue helps the blood to clot, and voila, you're done. Versus something where, you're trying to hold pressure and it just won't stop bleeding and patient's unhappy. And so it's now, I put it on my note all the time. I'm using the Brian Lynn technique. And so Brian published this in the medical literature, and then it made it into a blog. And then that is another way that information gets disseminated.
What are the big medical blogs?
The New England Journal has a couple. Emergency medicine has several, because we tend to be kind of a more kind of innovative.
The blogs you're talking about are blogs. They're basically websites owned by institutions, as opposed to.
Oh, not necessarily. There's one called Academic Life in Emergency Medicine that my colleague Michelle Lynn runs. And Michelle's an emergency physician at UCSF and SF General. And she just publishes ideas from
big doctor substackers. Are there big doctor substackers?
Yeah. Oh, for sure. Yeah. There's a publication called Rebel EM, and it's, Rebel Emergency Medicine. Like, it's analyzing research in emergency medicine and best practices in emergency medicine.
I love hearing about that, because obviously for a living, I work on supporting people who build things as founders. The fascinating thing in medicine is that there seems to be this aspect where you have high science, hey, we found a new drug and we used a new technique. We made a new kind of machine that uses whatever. And then there's almost like body carpentry. I don't know if there's a term for that in medicine, but what you're describing from your colleague getting chopped off at the end, doesn't sound like a lot of high science other than maybe the numbing agent. It sounds more like really thoughtful, intentional methods for body carpentry.
Yeah, sure. And I think that's the other thing that emergency medicine is really good at, is we're always like, how am I going to make this work?
You're MacGyvering that stuff. You're like, hey, does duct tape play a role?
No duct tape, but we sometimes use sugar.
Huh. What is sugar used for?
You really want to know?
Yeah. No, this is fascinating.
So there's a thing called a rectal prolapse where part of your rectum comes out of your anus. And so it makes a big boggy, kind of soggy mess. And it's very painful and it's very uncomfortable. And because it swells so much because of the blood supply of the rectum, it's really hard to push it back in. And so if you pour sugar packets on it, it will suck the fluid out of the rectum and make it less spongy so you can push it back in.
Fascinating. Okay, I love that. Wait, what are some of the other practical ER techniques?
Black tea bags. So if you have a bleeding either wisdom tooth or you've got a bleeding cut on your lip, the tannins in the tea will help to clot it a little bit faster. So we'll use black tea bags. You can use a tongue depressor and have the patient bite down on it. And if the patient's able to break the tongue depressor, it's very predictive that they actually haven't broken their jaw. So if somebody gets punched in the jaw and they're having jaw pain.
So basically, if you go to Starbucks and just grab an order to go and get one of those packets with like a sweetener, a little coffee stir, a napkin, you can solve.
A great point. I didn't even think of that. Yeah. We will sometimes also nebulize coffee. So sometimes there are some very foul smells in the ER, as you can imagine. And if you just take a nebulizer, which people will use for a breathing treatment to give, medicine to people with asthma, you can pour in some coffee into it and just hook it up to air and nebulize that coffee smell into the air, and it'll neutralize the smell.
Then sometimes they do create a company around some of these things. Is that sort of like any other occupation where, it's like, okay, I invented something. I'll start this company on the side. And if it becomes big, maybe I'll leave. I mean, we had a family friend who started a dental implants business and did very well. Is there anything different about that kind of entrepreneurship?
That's a good question. I guess I would just say the challenge is probably not even the person doing the inventing. It's probably just all the regulatory headaches of getting your great idea approved by the FDA and all the regulatory bodies that are deciding is this safe to use in a medical context.
Yeah.
Like the microwave in the ER staff room, or like the place where they heat up the patient meals or something like that, is like an industrial, healthcare approved microwave that probably costs $5,000 because the manufacturer decided to go through all the hoops to get it approved to be.
Sure. So sometimes the formality is required to overcome, we see that in tech as well, for sure.
Yeah.
So now let's talk about the aspect of a career, which is managing your life, because I think that's very different for doctors.
Yeah.
And this is also a place where off-call plays a role, among others. So, feel free to tell us more about it. But let's just start with money.
Yeah.
Do doctors make a lot of money? And how do you manage your money over the course of your career?
Yeah.
You have this insane, stable, high-paying occupation. And, I'm exaggerating the point a little bit. And so I guess the question is, as a doctor, how do you think about the role of money, both shelling out to learn and earning it over the course of your career?
Great question. I think that physicians understand that we are well compensated. And to your point, Roy, with a almost guaranteed high compensation for the rest of our careers, for the vast, vast, vast majority of us, if we continue to be decent doctors and good people, everybody always needs a doctor, and there's certainly a doctor shortage that's growing and growing. And so it's a very stable career. Interestingly, as an entrepreneur myself, I actually think that's one of the reasons there's not more change in medicine, is because
it's so stable.
It's so stable. The alternative is way riskier.
That makes sense. Okay. So writ large, you think that kind of supposition of the supposition of you pay your dues and all this lengthy training, and then the financial reward at the end is the security of a high-paying occupation.
Yeah, I think that's true. I think more and more physicians are starting to question the trade-offs there. And that's certainly part of the reason that we made Off Call is there have been market and societal forces that have changed that comparison as well. But I think any physician who does not acknowledge that on average we are paid many times over what the average American makes, is crazy.
So I hear that. And at the same time, my sense is there's huge variety across location and across specialization. And by the way, that it seems like American doctors get paid better than doctors do in other countries. I guess I hear complaints about it ain't what it used to be.
So a couple things on that point. I think physicians are generally highly intelligent people, hardworking people who could have gone into other high-paying careers as well.
So part of that psychology of that is about the alternatives of, hey, like if you went to a good college and then you could have gotten into medical school, you didn't have the option of going to be a high-paid investment banker or tech engineer or something like that previously, and now you do. So by comparison.
Yeah, I think there's also a sense that maybe some of our colleagues that were, just as intelligent or whatever, they finished college and maybe they just went off and started working and they paid off their college loans and they started a family.
Or
And
by the time you're done with your schooling, they've paid a mortgage on a house and, blah, blah, blah.
yeah, there's some people that look at, kind of more blue collar jobs like a plumber or an electrician who can get a job right outside of high school or trade school. And then from 20 to 35, maybe they're making a pretty decent income and don't have any debt or very little debt versus the physician has accrued $500,000 worth of debt at 35 and is now only just starting to think about things like buying a house, starting a family, buying a car, all these other things. And so there is a sense from, I think, physicians that there is significant delayed gratification, and that comes with some opportunity costs. And therefore, physicians, I think there's a general sense that we deserve a higher pay, maybe.
By the way, I have yet to meet anybody in any occupation who does not feel that they deserve higher pay. Actually, I will say for myself, I'm fairly paid. I feel paid fairly for what I do, but also literally my job has the word capitalist in the job titles.
Yeah.
Tips. I know this is not advice, but I'm going to break that for a second and just ask you, if somebody were coming to you and saying, what should I know about how to manage my financial life?
Yeah. The number one tip that all of my attendings told me, and that I think I followed pretty well, is, once you're making attending money, so you're done with your medical training, residency and or fellowship. Once you're making, and you're attending money, some people can go up probably 5 or 10x what
Sure.
they were making as a resident.
Because it seems like residents get paid mostly like students with a stipend as opposed to people with a job.
Yeah. Many people will advise, hey, try to keep living as a resident as long as you can, because then that's just all that extra cash is coming into your bank account. You can pay down your student loans. You can buy a house. You can invest that money. You can try to kind of catch up with
That's really
other people.
Yeah, I mean, I thought that your advice would probably be about keeping expenses down. And the way I think of it is a low expense base is a form of freedom. And, I've saved since my very first paycheck. In every paycheck, I guess, except for buying a house, which is the ultimate form of unsavings.
Yeah.
The leverage you get from the freedom to not have your expenditures rise. And, oftentimes what I find happens is, especially with stable incomes, there's drift. In startup world, where, it tends to be that when people get paid, it comes all in one big shot. The equity turns out to be, but there are definitely some roles in big tech companies that pay very well, but the predominant pay model in the startup world is make money that's very good and good enough to live on, but like the big increases don't get baked into your baseline. People can oftentimes have the discipline to keep their expenses low. Whereas in finance, let's say, where you can make more money and you steadily tick up, I remember there was this scene in Billions where the guy loses it all and only has $20 million left. And Axe is talking to him and he's like, yeah. And he goes through how you could have $20 million and feel poor. And it's absurd, but the reason is because people allowed their standard of living to drift up and they allowed their sense of self to be attached to, well, if I can't pay to be part of the country club, who am I? And so that makes a world of sense. Are there other aspects of managing money as a physician that are it just seems like there's this stereotype of the stockbroker selling stock tips to the doctor?
I do think that physicians feel like we're an easy target.
Because you're smart, but not in that way.
Yeah. And so there is physicians tend to trust each other for all sorts of things that we don't trust.
Makes sense.
Other people for, but physicians will ask each other for financial advice, even though that's not our specialty, not our field, but it is a sense of this person's not going to try to screw me over. And I'm not just what do they call it? A stuck pig or something like that they can leech off of or something. Because we're also, we have a high good income and we're also super busy.
Yes. And okay, so I don't think of emergency room doctors as one of the especially better paid. I just don't know. specialties, like I think of like dermatology, basically things that serve rich people seem to get paid more. Plastic surgeons. What are some of the specialties that get paid worse, and how do people make their lives work?
Oh, well, I'll guess, Roy. Guess what the field is that makes the least money. The lowest is going to be pediatrics.
Oh, wow. That's fascinating. I had no idea.
And pediatric subspecialists are going to make a little bit more than a general pediatrician.
But a pediatrician, I guess that just surprises me, because our society seems to be willing to pay for a bunch of things for kids, not necessarily public school, but a bunch of other things. Wow, that's awful.
Yeah, it's terrible. And then the adult specialty that certainly by far makes the least amount of money is infectious disease,
because nobody wants to be there.
Nobody wants to be there. Infectious disease doctors are known to take the best medical histories and are the most in depth. Probably they're a close tie with rheumatology.
Rheumatology again? I forget.
Joints. So yeah.
I was thinking arthritis, but I wasn't. Yeah. Okay, sorry.
Yeah. So infectious disease doctors typically will have very in depth notes, because infectious disease doctors get involved when nobody else has a clue what is wrong with the person. And so it is the infectious disease doctor that will spend 45 minutes or an hour, 2 hours with the patient, getting to know every little nuance of what they do in their life, and what their hobbies are, and where specifically they traveled in Guatemala.
The specialty requires them to have clues into it. And maybe that's why many of them end up being the ones who can write books about how, what the patient's medical experience was.
Infectious disease doctors are some of the most dedicated physicians to the less fortunate and less represented. So
that makes sense.
Infectious disease doctors are the ones taking care of patients that have tuberculosis, that have HIV or AIDS, that have syphilis, that have they're taking care of patients who are sex workers, and they're supporting a population that typically is excluded from a lot of medical care.
Makes total sense. That makes total sense. And pediatrics pays less because there's just not as much demand for, people are cheap about spending for their kids' medical care.
I think there's a general sense that because most kids are healthy, pediatricians don't do much. And that could not be further from the truth. In the same way that adult primary care is extremely challenging, pediatrics is a mixture of treating and supporting the parents who have particular concerns, trying to address the actual patient who is the child and helping them grow into a mature and healthy adult, and then picking up, because most kids are healthy, picking up the needle in the haystack of, you might see 1,000 kids in 2 months or something like that, and finding the one kid that actually doesn't have the flu. They are just presenting with their first presentation of diabetes. And if you miss it, they're not going to have a good outcome. And so all of the, if 999 times out of 1,000, the kid is fine no matter what you do, well, people might not think that there's value in you catching that one.
It's sort of like being a security guard, which maybe I should do one of these with a security guard. It's like, people think it's easy because you're just sitting there. But the reality is you were just sitting there while purportedly on eternal vigilance. And eternal vigilance is basically impossible. And I could see that happening. Okay, so that's how the income shakes out. Are there performance bonuses for doctors?
There are, in a couple different ways. So, there's this RVU system. So that's relative value units. And that is the quantitative apples to apples comparison of the value of your work. So it's relative value units. And so everything that a doctor can do or bill for has an associated number of RVUs that they get. So seeing you in the office for a wellness visit is a low RVU thing because it's a relatively easy thing to do.
But extracting that bullet with one hand while hanging upside down from the ceiling, high RVU.
Doing a brain surgery, doing a complex care thing, and in the same way, I can take care of patients at different increments of severity as well. So in the ER, I can take care of somebody who's having a heart attack, and that's going to pay me or it's going to assign more RVUs to me than taking care of a splinter, obviously. And so it's an attempt to standardize the work that doctors do. And the RVUs are an attempt to standardize the value of the care. Now, unfortunately, procedures are highly valued and thinking is less valued.
Meaning that there's an incentive to do something that may or may not be in actually the interest of the patient.
Sure. Absolutely. Yeah. So if you're, I'm a salaried physician. I do not make a single penny more if I do more or less testing for you. But maybe most physicians have at least a partial bonus for how many RVUs they bring in because their health system is then going to collect more money as well.
So then you'd get that extra money. And just to say, doctors pass these things around back in the stockbroker thing, are there certain kinds of investments that doctors tend to make more than people in other occupations?
I do not know. That's a good question. I think doctors are probably known for being worse with their investments because there's a pressure that we think we're supposed to know everything. So we will sometimes maybe not ask for advice.
It's rare to have an occupation where you make a bunch of money, but you don't deal in money.
Oh, yeah.
Like lawyers make a bunch of money, but they're often involved in business transactions. The legal community has lots of people who know how to think about investments because they work on them as lawyers. The finance community, obviously, that's kind of what they do for a living. And so what's rare in medicine is the combination of liquid income, available income, and absence of a professional reason to engage with money.
The intent, I think, behind that is to make sure that we're not treating people based on money. But the consequence is that there's like a third party in the middle that, makes kind of nobody responsible for the cost of medical care as well.
I want to we talked a little bit about work-life balance in the context of managing the hours, the stress and the burnout, family relationships and how you navigate them, building a family, building friendships. Like, how do you make friends as a doctor when you have that weird schedule where it's like, no, I can't come to, Jane's baseball game or whatever?
Yeah. It's interesting. I think it's another reason that many doctors are friends with other doctors and nurses is we understand that we've all kind of agreed to take this oath thing that says like, hey, sometimes we're going to miss family events or because we agreed that these patients should come before everything else. Certainly as a shift worker and a shift worker that works, days, nights, swing shifts, weekends, holidays, it's kind of baked in to my life with my husband that like, oh yeah, hey, this year I won't be available for Christmas.
Is your husband a doctor as well?
No. He's not in medicine at all. But, there's just an understanding that I think I've worked almost every single Thanksgiving for the past 13 years. And so we do a Thanksgiving the day before, or we do it afterwards. My family and we've started doing like a belated Christmas in January, partially because like the weather is really bad going back to the Midwest. And so and travel is less stressful. So we just do like a delayed Christmas with my family in January. And so I think everybody makes it work and figures out how to do holidays and the way they want things to work. But I mean, I grew up, my dad's a physician. I certainly grew up like, oh, dad has to go into the office or go into round in the hospital on Saturdays. And it's just, I think you kind of normalize it to some degree.
And boundaries with family around being a doctor.
Oh,
yeah. Okay. So you already have a thing because you were saying that one of the advantages of being a doctor is you can ask other doctors for free medical advice. One of the disadvantages is like, look, as a venture capitalist, let me tell you, anybody in my life has somebody who's got a business. At some point, it is coming my way. I mean, I hope that maybe it won't. And I like it, by the way. I enjoy my occupation. But there is a moment, I'll just share an example where I had a friendship with somebody. I still have a friendship with him. He would ask me for advice about his startup. I would happily give it to him.
Yeah.
His startup was in the domain that we don't invest in at all. And then, a couple of years passed and he came back to me with another startup and he was asking for advice. And I was like, wait a minute, this is the kind of thing we invest in. And you're asking me about advice about another investor. What about us? And he's like, well, I just love your advice. I was like, dude, that's kind of like calling a cardiologist and asking them to do, free open heart surgery. Like, this is what I do for a living. And so, and it was awkward. And I haven't had to navigate that very much. Usually it's pretty clear. And by the way, we would invest in businesses run by people in our lives because our incentives are aligned with our LPs. We need to make money. How does it, like, are people always asking you for medical advice? And how does that work? Where do you draw the line?
Yeah, I think they've stopped because I had to learn to set boundaries.
Okay, so tell me about what that journey was like and how you manage it as a doctor.
Yeah, it starts in med school and your family knows that you're in med school. You don't know anything, but you certainly know more than anybody else they know. And so, your family will like text you for advice, or like, friends from college and high school.
Sure. I mean, I've texted my doctor buddy, been like, hey, I've got this, like, I'll take like a picture of something and be like, should I go to the doctor?
I think then it certainly gets worse in residency and then later as an attending because you are like a doctor. You are an expert. You have so much more knowledge than 99.9%.
You can ask you to prescribe them drugs.
I think my family and friends know that I really do not like giving out medical advice because I think it's impossible to be objective. I will fully admit that I have both diagnosed some friends with appendicitis that I was like, oh, I got that diagnosis right. And then there's other friends that I've like totally not considered a serious problem with them because they're my friend. I'm like, oh, my friend wouldn't have a collapsed lung or something like that.
A close personal relationship might cause you to give bad medical advice.
Absolutely.
Makes sense. That's really responsible of you.
So I think you try to walk a balance of giving people some generically helpful advice like, oh yeah, I think that's something that could probably wait a few weeks, but yeah, it'd be reasonable to see a dermatologist about this. Or, hey, what you're telling me is really concerning. I think the ER might be an okay place for you to get seen tonight or something like that. But I certainly shy away from giving specific advice like, yeah, this is, oh man, that's cancer, or oh man, that's whatever. And I certainly do not prescribe or refill meds. And part of that is ethical. I do not have the time or energy to be refilling all of your meds. And I cannot be a crutch for you and your choices to not like keep your meds refilled with your own physician.
That makes sense. Does it change when it's somebody very close? A mother.
Yeah, of course. I mean, I will tell my mom or my husband or something like what I could do to help them. Like, hey, do you want me to call the urgent care and see if I can help get you in sooner?
Find a way to support them. You just lean forward a little bit more on supporting them, but not necessarily providing the medical care yourself.
Yeah. And, sometimes I'll say, yeah, I think you'll have a better appointment with PT if you jot down already what you've already tried or what medicines you're on.
Tips on how to be a good
tips.
patient.
Yeah.
Okay, that makes sense. And then there's an aspect of this, which is also doctors getting care from other doctors. You talked about it as a perk. Now I want to just talk about it in terms of patient experience. But doctors, my understanding is, receive medical care differently from others. And so tell us a little bit about how doctors are in receiving care from other doctors as patients.
I feel like both people in the relationship are doing this really uncomfortable dance because we don't want to offend the other person, but we also don't want to treat them differently than anybody else. Like, I think every doctor knows a VIP patient, meaning, maybe they're a rich, fancy person or a celebrity or something.
When our son was born, the people in the room next door in the hospital seemed to have something special going on. Difficult issues going on, but maybe some VIP treatment. And then a couple of years later, that wing of the hospital was literally named after them.
I think every doctor has seen a VIP patient that actually gets worse care because they have too many cooks in the kitchen and they want all their specialists to get involved. But when I'm treating another physician, maybe it's all in my head, but I feel like it's way harder to read them and what they want. And, I think some doctors want to just be treated like other people, everybody else. Some people want extra tests, or they feel like, hey, this is not my wheelhouse at all. I'm a pathologist. I have no idea what to do with this arrhythmia. So just do whatever you want to do. And so you're trying to do this dance of like, keep them informed, but not overdo things, but not underdo things either. And so I try to just like call it out and say, hey, I know you're a dermatologist. Here's what I'm thinking the differential is. Is there anything on your mind that I'm missing?
You're trying to make it easier for them.
Yeah. And I'm trying to also work with them. I don't want them like in the back of their head thinking like, oh God, this idiot,
Sure.
why isn't he considering this thing that's really common in my field?
And I guess there's also, for some of those doctors, the possibility of some professional consequence, either advantage or disadvantage based on how you show up as a patient, because they're thinking about, are you smart? Do you seem to have good judgment and stuff like that? And that seems really scary too, to think that, the way I receive medical care might have a professional consequence for me.
Certainly as an ER doctor, I call a lot of consults. And so the people that I'm treating who come into the ER for,
You want them to do a good job on your consults.
yeah, I don't want them to like see, damn, Walker's texting me again, and and be like loath to talk to me.
Okay. And then there is this particular thing of how doctors sort of may have a secret in what they know that affects end of life. What do doctors know about how to die?
I think a lot of physicians, especially those of us in the hospital or the kind of the more where they're sicker patients,
Where you see death more frequently also.
yeah, and certainly in I think oncology and other fields that deal with life and death commonly, I think there are a lot of really bad ways to die, and I think there are definitely really good peaceful deaths as well. And I think many physicians, and I think this is also true of a lot of ER nurses and ICU nurses, especially, have very different goals, values, and expectations for the end of their lives than the lay public, like dramatically different.
In what way? What do you mean?
I've told people all the time, if I end up having dementia and I'm a significant burden to my family or my caregivers, or I'm just yelling all the time and I'm causing trouble for the ER nurses, I don't want to live like that. I don't want to be a burden onto other people. That does not seem to be the same values as many other patients that
makes sense. Or their family members. I mean, and I also think there's an aspect of this that's about just greater familiarity with what happens, that isn't necessarily about a different orientation or attitude. It's like, listen, you just seen people die a lot. You're going to relate differently to death, is my guess. And, that Ken Murray piece from whatever it was from 15 years ago about how doctors die, I'm not fully I'm sure I'm not going to exactly get this right. But what I took from it was roughly that one thing doctors know is there's not that much you can do at the end. And so you might as well just kind of go off peacefully into that good night. And, therefore my guess is doctors be more likely to choose hospice care over, and I've read all these, kind of things that it's oftentimes the least effective end of life interventions. It's like extend your lifespan by 2 weeks with some crazy expensive thing. And on some level, I don't want to say who cares because every day of life is precious, but it's like 2 more weeks in the hospital versus, a chance to say goodbye in a dignified way to your family.
Yeah, I have two reactions. One, most people's experience with death and dying is very rare in the real world and not that uncommon on television and in media. And, they did a study like in 96, the New England Journal published a study looking at ER and Chicago Hope and how often CPR worked. And so most people, of course, think that CPR works.
Because it always works on TV.
They shock the patient and they come back to life and they're talking. That is not how CPR works.
Meaning CPR rarely works, is what you're saying, or much less often works.
Much less often works. And, I'll give you an example. Say your loved one is dying of liver cancer and their heart stops. Well, even if I am able to restart their heart, probably the reason that their heart stopped was due to their liver cancer, not their heart. And so, great, I've restarted their heart, but now they're even sicker. I've maybe broken some ribs doing CPR to them. Now they're in more pain. They're on a breathing machine. They cannot talk anymore, and they still have liver cancer.
Yeah.
And so it's a little bit utilitarian or like kind of fatalist that I think physicians are way more open to, like you said, hospice care, palliative care, because we have an understanding that like CPR is not going to fix.
And palliative care just means like, don't try to fix it. Just make the person more comfortable while they suffer from it.
Yeah. Palliative care is a group of specialists that is sometimes overlaps with hospice, but not always. And palliative care helps anybody that has any serious illness. So that could be somebody who's going to totally survive their cancer. That could be somebody who has dementia or has any serious illness, and it's having a place and a person and often a team that can help the patient process that and talk about, hey, what's important to you? What are your values in life?
Yeah, I read this book, Between Two Kingdoms, that was about a young person's experience with cancer, just understanding how many of these complex choices there are around, well, is this going to actually help, or is this about my experience, and dot, dot, dot. Okay. It seems like one of the themes has been the community of doctors, and off call seems to activate that community in useful and interesting ways. So I just want to give you one full throated chance to be like, how is off call useful to somebody who wants to be a doctor?
The challenge of medicine today is, like we talked about, Roy, it's not just about the money. It's about all of the little things that make a really good job good or bad. And it's trying to bring, I think, some of the leverage and power back to physicians who have lost a lot of that leverage and trust and autonomy, honestly. As it's like 78% of doctors are now employed by somebody else. Usually that somebody else is not another doctor. I'm very fortunate. My medical group is all run and physician owned. It's fantastic, but many are not. Many are owned by private equity or a corporation or shareholders. So while the doctor has still taken the Hippocratic Oath and is still trying to provide the best medical care possible, they have significant pressures from other people that change how they practice to some degree. And so the more the doctors can have transparency and can band together and work together, traditionally in a space where doctors don't all band together, we band together by specialty, and then everybody else we disagree with. So if we can find ways that we can all find common ways to work together, I think it actually will make doctors happier, make fewer doctors quit or leave medicine, maybe practice longer, be happier. And generally, I think if you have a happier, less burnt out, less unhappy doctor, patients are going to benefit from that too.
And so, how does off call help them do that exactly?
So, we are allowing doctors to confidentially, anonymously share information about their work, their job. So that's not just salary, but that's how many hours do you actually work per week? Not what your contract says, but how many hours are you logging in from home to finish notes? How often are you taking your laptop on vacation to Mexico so you can reply to your patients? Do you supervise NPs or PAs? That can add or subtract from your happiness. What's the relationship like with your administration? That matters greatly. So all of the little pieces, we're trying to quantify that and turn that into what we're calling the salary score, to help doctors have a way to compare jobs, have a better chance to negotiate with their employer when their contract comes up for renewal, or maybe decide to go independent again.
We've seen that in other occupations and hasn't quite worked in medicine, Glassdoor, Levels, One of the things that I think as a person who is interested in ways that working people organize with each other, it's a form of organizing. I mean, you're creating a platform where the free exchange of information in a mediated, specific way can produce value for the collective. And so I think it's actually a perfect transition. And so anybody who is a medical professional, a doctor, specifically who is watching this should obviously go and sign up for Off Call.
Yeah, offcall.com.
Yeah, there we go. And listen to Graham's podcast, How I Doctor. The last section of our conversation, which is going to be a little bit more rapid, is about the broader system in which doctors work. When you think about the broader system, what are some of the most pressing aspects of that you think about that are important to understand or need change?
The incentives of payment. So payers, pharmacy,
insurance,
pharmacy, hospitals, the big 4 or 5 players in that drive the healthcare system.
So what we're going to do now is I'm just going to give you a few aspects of the medical system and just get your one sentence take.
Cool.
Incentives and payment.
Very perverse and need to be radically disrupted.
Obvious answers on how those things need to be changed.
Force. Mark Cuban has convinced me of his idea that we need forced transparency of costs, and that actually will rapidly drive change.
Seems like it. PBMs. I keep reading about them, but I don't know what they are.
They're technically supposed to cause employers and health plans to save money, but they have like a 7 pass the football back and forth system that actually makes them a lot of money and dramatically increases the work for doctors and their patients.
Pharmaceutical companies.
I think really important and do a ton of good, but also do some pretty nefarious things to extend their patent life and, maintain their monopolies for as long as possible.
We're going to talk about some governmental stuff. That Medicare for all.
Fantastic idea, also known as single payer, that I, for many years, supported. I'm less convinced that it will work in the United States, unfortunately, due to all of the complexities we're talking about right now.
The Affordable Care Act, also known as Obamacare,
did a lot of good to expand access to care for millions of Americans, got rid of pre-existing conditions, which are no longer a thing that anybody talks about anymore, but also created some massive loopholes that have driven record profits for United and Optum and, ways to game the system further.
The murder of the United CEO.
Totally unacceptable way to voice your anger, frustration, anything with any policy anywhere in the world, but certainly caused a massive reflection by the entire country on how the health system works.
Some of the socioeconomic side of things. Income inequality, wealth inequality in America, or the settings you've seen, and their effect on medical care.
No other factor is a larger contributor to the cost of medical care in the United States. If you have somebody that is working 3 jobs to make ends meet, they are not able to eat healthy. They are not able to have time to exercise. And if we actually reduced income inequality, we would actually save money on healthcare.
Yeah, I kind of think of guaranteed income as the Ozempic for all. Ooh, Ozempic.
Extremely powerful and effective medicine for reducing weight, which also has impacts on diabetes and cardiovascular health, is to some degree a miracle drug for many people, but is extremely expensive. And it feels unfair that the United States pays so much more than anybody else for it.
That makes sense. And I hope we put it in the water once we know that it's safe to do so. Okay. But related on socioeconomics, immigration and how it relates to the provision of medical care. You see a lot of people just wandering in the door without knowing if they're documented or not.
Yeah, extremely proud that I'm an ER doctor, that I could care less if someone is documented or insured or not. I think actually if we were able to optimize the health system in the United States and get rid of a lot of middle management and bureaucracy, it would be no problem at all to deliver care to people that are not documented in this country.
Other forms of difference, discrimination, gender, race. I mean, we talked earlier a bit about some of the fact that the studies come only from certain communities and about the importance of affinity between and maybe background and similarity between the medical care providers and the patient. Are there other ways that these kind of systemic differences around race, sexuality, gender, et cetera?
Yeah, I'll tie into my other favorite topic of technology, informatics, and AI. So we know that humans are biased. We know that the medical system is biased. AI will be based on what already exists in the data. And so we should expect and look for the bias that's going to exist in AI so that we can address it, not pretend that it won't be there or hope that it won't be there.
Labor organizations in medicine, unions.
Fascinating topic. I think unions can be really good for making sure that healthcare workers and healthcare professionals are not abused by the systems. At the same time, I think unions can make things worse for patients, can pit healthcare professionals against patients. And I don't think that's a good system either, but I understand why the unions exist as well.
Yeah. The American Medical Association. We don't often think of it as a labor organization, but in principle, that's what it is.
Yeah, all of these specialty organizations are at least partially trying to get more for their members. My organization included. They lobby on behalf of their members.
Your organization, meaning the American Medical Association.
Oh, no, the American College of Emergency Physicians, that my specialty organization. I think I'm seeing some really positive indicators for change at the AMA. Most people don't know that most doctors are not AMA members. I'm not an AMA member. The AMA has actually killed what was termed socialized medicine many times in the history of the United States. To, again, to support physicians, but I think it's had very negative consequences for what we're dealing with now. But I'm seeing really surprising amounts of political change at the AMA. I think the AMA even made some comments about calling for RFK's resignation because of what RFK did to the vaccine panel.
Do we need more doctors?
Yeah, I think we do. The way I see it, unfortunately, because our population is getting sicker over time with chronic disease and chronic illness, and that's one of the few things I agree with RFK Jr. about. I think we're going to need more doctors, and we're going to need a lot more AI to help us deal with the increasing burden of disease that's from my age and older, middle-aged people and older. We're all going to be living with diseases longer and longer, and that requires more medical care because there are more complications, and that's the trade-off. The alternative is death. And so we've done an amazing job at keeping people alive for longer, but the alternative is, well, they're alive, and so they need more medical care.
More medical care. Should it be easier to become a doctor? Shorter school?
I don't know if it should be fewer years, but I think the curriculum and the training system absolutely needs fundamental change. It is based on a report from the 1910s from Johns Hopkins University that really looked at the disease burden in the United States was many things that could be cured. And that is not how the world works anymore. We are, again, managing chronic illness. And so I think we need drastic changes in how we educate and what we spend time educating.
Fascinating.
I'd love medical students to stop memorizing chemical pathways and spend 6 months on how to communicate better with other humans. But we haven't chosen to do that yet.
Love it. All right. Last question, and then we're going to wrap. Somebody comes to you and they're like, I'm thinking about being a doctor. What do you say?
I'd say it's a tremendous privilege to take care of a patient who needs your help. And it is one of the best feelings in the world to be able to fix somebody and take something that is really scaring them and give them some medicine and make them all better. But at the same time, medicine's going through some drastic changes. And right now is a really rocky time for our profession. I'm hopeful that AI and regulatory reform and more physician leaders will help us get out of the rut and back onto the right track. But know going into it that there's tremendous change happening right now in the profession.
I actually believe, by the way, that a bad time in an occupation is the best time to enter it.
Sure.
Because you're going to go through a bad time over the course of your career anyway. You don't want it to hold you back, unnecessarily lose a decade of your life. But there's a lot that can be said for entering exactly at a time like that. So we've covered so much range. Dr. Walker, Graham, thank you. It's astonishing. I am so excited.
We really have
to share this. It's really great. And I think something quite different. And I'm just grateful for everything that we have talked about. And it's going to be ricocheting around in my head, a lot of it around the shifts in the system and how you think of yourself as a care provider on a team and et cetera. And I just want to say thank you.
This was so fun. Thank you. This was fantastic.
Thanks for listening to This Is Not Advice. If you want to hear more from Graham, you can check out his podcast, How I Doctor, and you can visit OffCall at offcall.com to see how physicians create transparency around pay and around their working conditions. And if you're a doctor yourself, you can add your data to help the entire medical community. This Is Not Advice started out as a series of hundreds of short answers to people's dilemmas about work, usually in an office, not an ER. And if you're interested in hearing more, you can go over to the website, thisisnotadvice.work, which is a guide based on all those questions and answers, which anyone can edit. If you made it this far, I'd love to hear what you thought of this experiment of doing a long form version of This Is Not Advice as a whole occupation, especially this episode, which ran many hours, because as my coach tells me, your feedback is a gift. I'm Roy Bahat, and thank you for listening.